Okay, it looks like everyone is in attendance and we are ready when the committee is ready to begin.
I didn't do a mic check, but can you hear me well? This is Marcia.
Loud and clear.
All right, I'd like to start our meeting today by having the Audiology Practice Committee members meet first. And I'd like to call roll to make sure we have a quorum. Please say aye if you're here. Karen Chang.
Aye.
Tulio Valdez.
Aye.
Amy White.
Aye.
And of course, I'm here, so I believe we do have a quorum. I'd like to ask for public comment for items not on the agenda. So if the moderator could open so I don't know if there's any public comment on
We are now open for public comment. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand. We're going to take just a moment now to see if we have a request for public comment. Seeing no requests for public comment, do you wish to return to the agenda?
Yes, please. So moving to agenda item 3 for the practice committee, discussion and possible action regarding audiology licensing requirements related to supervised clinical and professional experience as stated in BPC sections 2532.2 and 2532.25 and Title 16 CCR sections 1399.152.2. I'd like to turn it over to Charisse if you'd like to make some initial comments about this issue.
Thank you, Dr. Raggio. So as part of Business and Professions Code 2532.25, B2 requires the submission of evidence of no less than 12 months of satisfactory completed supervised professional experience or its part-time equivalent and under the supervision of a licensed audiologist. This experience has to be completed under the direction of a board-approved audiology doctoral program. Those are all the current requirements in law. And the other current requirement is that the RPE follow the completion of the didactic and clinical rotation requirements of that audiology doctoral program. The board became aware that this was causing difficulty for some of the students and also hardships for audiology doctoral students and programs, and it may not support adequate consumer protection. And so in November of 2020, the board approved a 2021 legislative proposal that would have modified these provisions to allow some of the supervised clinical rotation hours to be counted towards the 12-month supervised professional experience. This proposal was included as part of the board's sunset review process this year in 2022, where the board recommended changes to its Practice Act, and the Senate Business Professions and Economic Development Committee and the Assembly Business and Professions Committee as a joint committee for sunset reviewed the requests, and they agreed to some of the board's requests as part of the sunset, but not all of the proposed amendments. And so currently, what will be offered as part of the board's sunset is in the memo, and it is referenced a little bit of cleanup in subdivision B, pardon the paper noise here, to clarify in B1 that the direction is of an audiology doctoral program at an educational institution approved by the board, and for B2 in relation to the professional full-time experience, or what many call the externship, is that the requirement that it follow the completion of the didactic and clinical rotation requirements of the program, that has been removed. So the committees were not willing to go with reducing the 12 months or allowing some of the clinical rotations. Per se of Part B1, that they didn't count towards the 12 months. But they were willing to remove the barrier that they have to follow completion of all didactic and clinical rotations. So now that would be simply when the board determines it's appropriate to apply, or when the graduate program determines readiness, that's where we would get to. So the statute would allow those doctoral students to start the RPE experience before completion of didactic and clinical rotation requirements, if the board believes that's an acceptable way to go. The board still has lots of room within the regulations where we have not really defined as much about the clinical what a clinical rotation is, or a clinical practice, I believe, I'm sorry, is the statute. Yeah, supervised clinical practice versus supervised professional experience. And so now that we know that we didn't get as much leeway in the legislative arena, and we know the final language, we can kind of resume discussions of how to proceed with updating the regulations related to the clinical practice and professional experience, and kind of take on what needs further clarification, definition, and some of the issues for consideration are on page 2 of the memo, and whether or not the number of clinical experience hours required for licensure should be updated to better reflect the requirements of current doctoral audiology programs. If there's a need to further clarify what actually qualifies as supervised clinical practice with individuals representative of a wide spectrum of ages and audiological disorders, as required in subdivision B1, or is the current regulatory requirement of 3 different clinical settings sufficient? Keeping in mind that those 3 different clinical settings is the same requirement it's been since it was a master's program. And then should a new regulatory section be created to specify requirements related to the supervised professional experience that is separate and distinct from the requirements related to supervised clinical experience in Title 16, California Code of Regulations, section 1399.152.2, because there's currently not a subdivision or section on just the supervised professional experience in the regulations there. Or are the general requirements in subdivision A of those regulations all that's needed? And then there also is questions of, should the board place any limitations or caps on certain types of clinical and professional experiences? For example, on the number of hours or weeks that can be accrued via simulation. I know that was part of a discussion at one of our committee meetings. And then should the board require programs to submit verification of the clinical rotation hours or professional experience hours in some sort of log or spreadsheet? Most of them are tracking in some sort of system. Or is the training program director's certification of meeting the requirements in the verification of experience form or in the university recommendation form sufficient? And then are there other clarifications needed for these clinical rotations or professional experience that should be codified in regulations that currently are not? So as part of your materials, board staff in coordination with the chair of the practice committee here, develop survey questions for audiology programs to provide the board with programmatic information pertinent to potential regulatory changes. The draft survey questions are attached for the audiology practice committee to consider. The committee may want to discuss whether the survey is still necessary and whether or not changes in the statutory language due to the statutory change, and if necessary, determine what questions to cover and if all those areas are covered. And so the way we have it set up is to provide a little bit of background in the survey on why we're asking for this information. obviously get who's going to be responding from the university or college, and then get the program's perspective on some of these issues. We've run into some of them, you know, special consideration for out-of-state programs, or students with special federal visas, and things that the programs can do to make it work for those students. Other issues, you know, directly asking about the 3 different clinical settings requirement. Without a specified number of settings, how would your program verify the clinical rotations provide sufficient clinical practice with a wide spectrum of ages and audiological disorders? My mouth cannot talk. And so it asked quite a few questions about kind of the program's perspective on some of these issues, and then also asked questions about the specific audiology doctoral program that's responding, about how their externship is set up, total number of hours, types of supervision, when it begins, whether or not they use software tracking to keep a log of students' hours, and then also questions about the supervised clinical practice requirements, including the types of clinical tasks performed and whether the average level of supervision, and whether or not that, I think there's a tiered supervision level, something like that. And then, the gradual decrease in the amount of supervision as they gain that clinical experience. And then when the clinical rotations begin, whether it's all the way throughout the program, including the first year, or if there is some amount of coursework required before the clinical rotations begin. And so those are the questions we developed from the discussions at prior meetings, along with keeping in mind the changes to the statute that have been made since those meetings. And now I will open it up for questions from the board members.
Let me kind of manage this, Charisse.
Yep.
If I can have the audiology practice committee members, if I can draw your attention to the issues at the bottom of page 2, I think we should just start with our discussion there and try to answer some of these issues with our opinions and knowledge about this. Starting with, should the number of clinical experience hours required for licensure be changed to better reflect the requirements of the doctoral program? And I'm sure you're all aware that currently the regulation is that you only have to have 300 hours, and that's a holdover from ASHA days and master's degree days for audiology licensure. But now that we have a doctoral profession, most AUD programs, not only in California, but across the United States, are requiring 1,800 to 1,850 clock hours. So I would be in favor of changing that language to include some number like that. Any thoughts and discussion about those numbers?
This is Dr. White. I absolutely agree. I would be in favor of changing those clock hours to line it up with what's required at the university level for the AUD. I did have a question, and maybe a precursor before we get into these items, and then just trying to understand right above those bullet points, you know, due to the negotiated amendments as of January 1st, 2023, the statute will allow students the ability to start their 12-month professional full-time experience before the completion of a didactic and clinical rotation. I'm just trying to understand if they're starting the quote unquote 12 months prior to the completion of that education, let's say in the 3rd year of graduate school, for example, is it a continuous 12 months in the sense of right now, isn't the 12 months defined as full-time versus part-time based on how many clinical hours per week are being put in? And if so, how does that fit into the 12-month window? I guess I'm a little confused.
my interpretation of that is that it wouldn't be continuous necessarily the way an old RPE used to be or a CFY is, but rather we would allow, let's say, for example, there are clinical rotations that occur starting in year 2. That the time devoted to those clinical rotations, fully supervised, of course, would count toward the RPE time frame. That's how I see it. If there's somebody who thinks differently, please speak up.
So then is the 12 months more, is it more saying that 12 months is equivalent to whatever the clock hour requirement is? I mean, it
I don't think it's hours. I think it's
yeah,
time.
yeah.
It's time. At this point, I'd really have to look through what currently is occurring in terms of 12 months. How many hours per week is that?
It's a minimum of 30 hours per week for 12, or for full time. To complete the RPE in 12 months is a minimum of 30 hours per week average. And then to complete it, I think the wording as a part-time, it requires, I want to say it's a minimum of 17 hours on average per week. It just says that's the equivalent. It doesn't obviously have a clock hour requirement in there. So just
Well, I think that's something we have to address,
yeah.
perhaps in our questionnaire or survey
Mhm.
about that, because I don't think we wanted to look at clock hours and
Right.
make that the metric. It is a time issue.
Right. I guess just if we're assuming that hours, let's say the RPE starts in the second year, how many clinical hours per week are these students putting in at that time? I think right now it's about a day, they have one clinic day, maybe a week. And then in the third year, that's 2 clinic days a week. So then is it 12 months on a part-time, under that equivalent, part-time equivalent to a full-time of 30 hours per week? Is that just the assumption then that it would be a part-time, so it would take longer than the 12 months?
Yeah, we may have to rewrite all of that so that
Okay.
it doesn't reflect that way anymore, since
Okay.
we're going to be doing this quite differently now.
Okay.
And
So we're
trying to
able
log
to rewrite that, I guess, is what I'm asking too.
Yes, I presume we will have to do that, along with many other things,
Okay.
to make this fit a better
Makes sense.
model for the students and the programs.
Okay.
So,
Perfect.
but yeah, that's good for us to keep in mind and probably undergirds much of what we're going to talk about here.
Mhm.
But that's how I saw it, is that at some point, likely not the first year of an AUD program, but it's starting second, most of the programs do have some sort of rotations that begin there. So we're working, if you look at the survey questions, you'll see we're asking about metrics that are used to log in and chart how much time is spent in each of these activities, and the supervision level and so on. So there's a lot of nuts and bolts, brick and mortar elements to this that we have to develop.
Yeah, and if it's okay, because I'm my train of thought at the moment, on that survey, I was wondering, would it be worthwhile to get an understanding of when they think the students are the ones performing the activity as opposed to just observing the activity? In other words, if in the first year they're observing clinic rather than performing most of the activities themselves, and then the second and third year they're moving into actually doing the testing or procedures themselves and being supervised, would it be worthwhile to know when that is generally occurring in these programs?
And you'll see if you look at the survey questions, it does approach that. I don't think it uses the word observation though. So that may be something we want to add to one of the questions, but we certainly are trying to get at when do they begin? When do they begin in earnest actually as participants and not observers? And what types of activities are they doing and so on. So there's a lot of nuts and bolts, including that, that we need to ask about. So let's keep that in mind about, where's the break between observation and participation?
Right. Yep.
Okay. So you're in agreement, you said, with the idea that we change the number to, do we want to say a minimum of?
I think so.
And as far as I know, usually it's a minimum of 1,800. I'm not sure if anybody knows, Amy, if there's a lower number that students are allowed to, like, do some programs have 1,600 hours?
I don't know off the top of my head, and I imagine that's part of the survey that was put together here.
Yeah, so we'll have to ask if that, Sharice may know if there's an actual definitive question that says, how many are you currently requiring? And if not, that's not in there, we should add that.
Mm-hmm.
The second issue it says here is there a need to further clarify what qualifies as supervised clinical practice with individual representative of a wide spectrum of ages and audiological disorders? In the past, it used to say 3 different settings. Again, that's a holdover from the master's level days and ASHA requirements. And the language was changed a while ago to say a wide spectrum of ages and audiological disorders. Should we be asking for more specific information about that, put some meat on those bones, or do we leave it to the programs to decide that they are providing training on different ages and audiological disorders?
I feel leaving it to the programs and just leaving it as a wide variety is sufficient. I don't feel necessarily that we need to define that.
Any other thoughts? Other
In medicine, normally there's national guidelines of the minimum required cases. Is there anything similar in audiology?
There is if you're seeking certification. They have the ASHA has something called a CASA form, and it's a form that you fill out that shows what the standard was, how you met it, what course you met it, how many hours you did it, and so on. So there is, but that's different than licensure. I'm not sure if we want to get into that business of verifying that if the programs have some internal mechanism to make sure that all requirements have been met.
Is that part of the accreditation? Do you know?
It is probably for the CAA accreditation, but for ACAE, I'm not sure they quite do it that way. But let's look into that.
Yeah, I mean I agree. I think if it's in the accreditation, yeah, I know on the CASA forms for sure, but if it's in the accreditation already, I don't know that we want to get into the weeds there.
Yeah, that's kind of my feeling too.
I would agree.
Yeah. Okay, but we'll look more into those 2 accrediting bodies that most programs are utilizing and see how they are doing it. The next one is, should a new regulatory section be created to specify requirements related to the supervised professional experience that is separate and distinct from the requirements related to supervised clinical experience in Title 16, CCR Section 1399, 152.2, or are the general requirements in Subdivision A all that is necessary regarding requirements related to the supervised professional experience? So I'm just going to open that real quick. I read these things, but cannot keep it in my head. Okay, so 1399.152.2 is supervised clinical experience, and it just talks about the qualifications of the supervisor, the clock hour requirements, the 25 hours in another field. That's really the components that fall in there. So should we have more specific requirements related to the RPE that is separate and distinct from the requirements related to these that are listed here? And I would say, by virtue of what we've trying to do here, is revamp this. So I would say yes to that, especially since we are going to try to change the clock hour amount. We do have to talk about that 25 hours and whether we want that still to be part of it. So I would say yes, we should work on that. and not just rely on these, just to make sure that we have all our ducks in a row.
So are you saying then that we would be, so the supervised clinical experience here under 1399.152.2, that stays there in relation to something different, and then we have the RPE specifically separated out?
Yeah, I don't know. Let's, Charisse, can you speak to what the idea of that question is about in that regard?
Absolutely. So since 152.2 is really just about the clinical experience, so the clinical rotation, it's really only talking about 2532.25B1, which is the clinical practice rotation hours, right? So that kind of overarching hours, month, what does the experience actually entail? Is there supervision type parts of it? That kind of broad requirements for the supervised professional experience, it seems like you need separate sections. I know right now we do have the RPE license qualifications, but a lot more of that is about what's approved RPE, how to apply, what does your supervisor need to do, how many people can be supervised, and an evaluation. It's much more the nuts and bolts of the RPE than the overarching policy about the RPE. And so that's where it seemed applicable that we should kind of clarify 0.152.2 is about those clinical practice hours in B1, which might mean adding a section that just talks about audiology and moving yourselves out of subdivision C and making a subdivision E that talks about the requirements in relation to audiology programs. And then also creating a new subdivision that's about just clinical or a supervised professional experience, which could be a new section 152.4.
So though that wouldn't be redundant because one is pretty general. Is that how you're looking at it? And the other is very specific?
No, just that we should make a separate one that's about the supervised professional experience.
I mean, I don't see anything wrong with that. More clarity we have, the better, so long as we're not duplicating the information.
Yeah, agreed. As long as it's clear and not then muddied, like, oh, which one of these does this particular experience fall under?
Yeah, it does get a little confusing because there is the RPE section. The difference is it's a little more about the qualifications for that licensure and it's about the initial application and then also sort of the requirements for supervision in there, but not as much about, what qualifies as a professional experience versus a clinical experience. Are there any other limitations? That sort of thing. So less of about the licensing of the RPE and more about what is the supervision supposed to achieve? Are there any parameters around it, etc.
So I think that it makes sense to make those two separate things, if that brings clarity.
Yeah, agreed. It seems reasonable to look at that.
Okay, should the board place limitations or caps on certain types of clinical and professional experience, for example, on the number of hours or weeks that can be accrued via simulation? I think that's one of our questions in the survey. Everybody understands what you mean by simulation?
Yes, and to clarify, simulation isn't the same as telehealth, actually having a patient there and testing via telehealth. We're just talking about like an odd sim.
Like a what?
I'm sorry, like the odd sim program where it's just a computerized, you're just practicing on your computer as if you were sitting at an audiometer, but there's not actually a patient involved in the process at all.
Yeah, I think we have to talk about that with the programs. Some of them do offer simulated experiences because of especially COVID brought in a lot of creativity with that. That may be helpful and useful, but it shouldn't be a substitute for hands-on entirely. So I'm interested to see what our survey responses bring on that issue, and see that will help guide us in our thinking about this. That's what I think.
Yeah, I agree. I think it comes back, like we were discussing shortly before about observation versus actual practice, and the simulations are a great way of learning about how to do the practice, but certainly aren't doing practice. They aren't, patient care practice.
Right. But I mean, I'm making that as I'm pretty sure we do have a question in there. Sharice, is that correct in the survey about simulation?
Yes, there is a question about that on. I'll find it in just a second. The question 15 is about what types of activities constitute the externship right now. So if audiology simulations are allowed in there, and I think it's that one as well. I thought there was also a question on if they should limit it in the general your perspective. Thank you. I'm like, I know it's up in here, and whether or not we should distinguish when the hours of simulation. If we should have regulations that limit numbers of hours allowed for certain activities in question 10. So we tried to separate it out. What's your perspective on certain policy type questions, and then separate out what is your program currently doing?
Mm-hmm.
So in question 10, it's asking whether or not we should limit some of the hours for certain activities, such as non-direct patient contact or related shift hours or audiology simulations. And then in the actual what's your program doing now is also where they can talk about, what is their current program doing? And they can also even specify, because there'll be open text box, if, that it's something they used heavily during COVID, but they are now back to doing more in-person or more direct patient care, but that they're still using simulations, especially in the early years or whatever they're doing right now, and how they're still incorporating that as we return to somewhat more normal.
Yeah. So I'm glad we asked both from both directions. What is your policy? What do you think of doing this? Because in our earlier meetings with program directors, there was some contention that some people thought it was great and we should incorporate a lot of it, and others, saying that we should be realistic about that, and others said, no, that's not good training. So I'll be interested to see what people think about this. But I believe there should be some limitation on it. But we'll know more about how to look at that and consider what that limitation should be once we see what people are really doing.
And it might also be interesting to hear the input now that it's a couple years later. We've now had a few more years of trying these remote options, working with simulation, getting students back into the clinic with patients. So it should be very interesting to hear the input.
Okay, moving on to the next one. Should the board require programs to submit verification of clinical rotation hours or professional experience hours in some sort of log, or is the training program director certification of meeting requirements in the RP verification form sufficient? That's an interesting question, and a potentially thorny one. So I'd like to get the opinion of the practice committee members.
I think it almost, well, my opinion about it might depend on what we decide about the previous point about, should there be restrictions on simulations, et cetera. And if we're kind of withholding, sitting on that one until we get the survey back, I'm not sure how I feel about it until then.
Anybody else have some thoughts about it? Would we know in other boards, do they ask for such a document, or do they just rely on the integrity of the program because you've approved it as a program? That's sufficient, then we don't need to be looking over their shoulder about it. Dr. Valdez, do you have any knowledge about that?
So, as far as we normally believe the accrediting bodies, so for example, if there's an overall committee that supervises all these programs, that's how in medicine is done. And as far as simulation, we use it all the time, especially to train for the weird cases. We don't use it to test the people, but we use it all the time for training.
Yeah, I think it's a growing element as it gets more and more sophisticated, and most of the simulation programs that I know of actually have their own metrics for success in doing that activity. Um, so you do a computer program, and at the end, if you're not able to answer questions or provide information, you don't pass it and you don't get credit for it. So you have to do it again. So some of them are quite rigorous, and I'm sure helpful to the programs, but again, I just don't know how much they're doing it. But my feeling is that we don't need to, I don't think the board should take on one more professional evaluative task like this. If we can believe that the program is accredited and that we believe it is a worthy program, that we shouldn't have, other than some general number of hours or a time, we don't have to look at course by course and rotation by rotation to make sure they did it. Any other thoughts about that?
I don't disagree. I think that's a fair analysis there.
Yeah, I think we have to trust them just like we trust them now, to make sure that all requirements are met. And certification should make sure that that is the case. Not certification, sorry, accreditation should make sure that that's the case.
Yeah, and I'm curious about whether accreditation defines anything related to simulation hours as well and how they look at that.
Yeah, I don't know for sure how that works, but there probably is something about it. We can investigate that further. I think we should have something that verifies um, that they've met those requirements, but just a single yes, no box or number box or something like that, that somebody has to attest to. And then leave it to trusting in the programs and the people.
Yeah, agreed.
The last issue here is, are there other clarifications needed for the clinical or professional experience that should be codified in regulation? That's a broad question, and I'm sure that once we see survey results, we'll think of other things. Is there anything that you're on your top of mind right now about additions you'd like to see?
Not that I can think of.
I'm sure things will arise as we go forward. On page 3 of 3, it does talk about the development of the survey with a question at the end, wanting to know whether the survey is still necessary due to changes in the statutory language, and if necessary, to determine if the questions cover all areas of concern. Charisse, do you want to talk at all what prompted the idea that we wouldn't need the survey at all at this point?
It's just my, always check in and ask kind of a question and not just proceed forward. So if there are things we should be clarifying, let's go ahead and ask the questions so that we can best inform our regulatory process. And if we didn't think there was a need for that, or if it needed to be a much shorter survey, that we didn't need to know all the other information in order to clarify one or two things, then we wouldn't ask the question. But it does seem that we need to clarify quite a bit, and that this sort of survey would really inform those regulations and would be also a great underlying document for us. And so we would be much better informed about what's going on in the programs, in their supervised clinical experiences, in their professional experiences, and then also, their input on what policy direction they think would be best to prepare these doctoral students for licensure. So I think that all of that would be helpful. And then, of course, my knowing that I don't know everything, assuming that there are questions I missed and that I didn't think to ask that maybe we should. Definitely tried to review all of my notes from 2020 and different meetings and capture all the questions that we could. But definitely knowing that there is still always room for additional input, or there might be something I missed, or maybe something that's not even clear from the program perspective. It might be clear the way we asked it for us, but maybe not for their perspective. So that's always good to hear their input as well before I send it out. So I'm not sending out a confusing survey that just adds more questions than answers or something.
Okay, well, we'll go over the questions in a minute. I just wanted to put my 2 cents in that I think we're operating blindly in many areas without asking these survey questions. So as you said, Sharice, I think it's going to offer us a lot of information that will guide the regulatory language development. So I would say, yes, we still need to send out the survey. Anybody disagree?
Nope, strongly agree with that point.
And the program directors are pretty helpful. I mean, they really have been in the trenches the longest and really know what they're talking about. It's very helpful to us. So there are three sections to the questions in addition to the personal and program information. Would it be painful to read through everyone and put our 2 cents in about it, or any other thoughts about how to attack this? That may be the only way we know if it's missing information we want to know. And we can also explain why some of and Sharice can help with that too, why some questions are in here the way they are.
Happy to do so.
Okay, so, sorry, did I
Would you
interrupt?
like me to read them for you, each one?
You can, if you want, sure.
Okay. So under the Your Program's perspective on clinical and professional experience requirements for California licensure, the first question is, are there any special considerations for students from out-of-state programs or students with federal visas that make it difficult for them to meet program experience requirements or state licensure requirements? If so, please explain what considerations exist and any potential solutions to those considerations.
Does question, going to the end of that one, does question 3 already or also ask about federal visa?
It does. And 2 does as well. I think the first one's more about, are there difficulties and special considerations? And then 2 and 3 is a little more, how do you deal with them?
Okay. So do you want to explain why? I think most students who are enrolled in an AUD program stay in that program and graduate from there and go on from there. But Sharice does have experience with some other scenarios that have occurred that might be helpful for others to hear about that you mentioned to me.
Yes. So question 2 asks about how your program handles students coming from out of state who have not participated in a 12-month 4th year RPE And does your program enroll these types of students to allow them to finish the 12 months of professional experience? In some other states, I know of a student from Texas. His program only required 1,600 hours. And of course, then he was graduated, so he wasn't under the direction of a doctoral audiology program. But he also was already here in California and was wanting to apply for licensure. So he was stuck in the crux that he's got his doctorate of audiology, but he doesn't have the 12 months of experience, professional experience for licensure. So we tried to connect him with programs in order to complete the rest of the 12 months from the 1,600 hours to the 12-month mark. And he was able to get into a program, and they did enroll him so he could finish up his experience, and he is now licensed. But that was one of those situations where other states have different requirements, and so students may end up in that situation where they're actually done, but they come to a state that requires more experience than their program required. And so what happens then? Because while that person may have a doctoral audiology or a doctorate in audiology, they don't meet the experience requirement, and barring other things, maybe getting licensed in Texas first and then coming over, that makes it hard. You're done with your program, but you can't get licensed here in California. And is there any schools that are willing or have helped out students? I think we only know of one, and I don't have the name on me, but just knowing that that's out there, and if programs are willing, and that helps us when we have students that run into this problem to direct them where to go, if there are programs that are open to it.
I'm just wondering how this would work if somebody actually had ABA certification, if they could, and come to California with the very scenario you said, would they be allowed to have a license?
I think we would have to take a look at that. The reciprocity-like deeming statute that will include ABA certification come January 1, 2023. That would be something we could have to look at. Generally, the board has interpreted that deeming provision to have two subsections. One that says the certificate to the ABA or the CCCA would qualify you for deeming. There's also a subdivision B of that statute that says that if you didn't quite meet the requirements.
It's if you attain it in violation of the laws, right?
Let me just grab it so I won't botch it. But B says if an applicant qualifying for licensure under this section has obtained any equivalent qualifications in violations of the laws and regulations governing the practices of speech-language pathology, or has not met the requirements for licensure, he or she shall correct the deficiency to qualify for licensure. If the deficiency is not cured within 1 year from the date of the deficiency notice, the application for licensure is deemed abandoned. So even the deeming statute kind of has that provision that it's not meant to be a loophole, but it does have some conditions in B.
Okay.
That's usually why California students can't just stop their RPE and say, hey, I got my CFY from ASH, or I got my triple C's from ASH on the speech side, and then go ahead and license me. And we're like, whoa, whoa, whoa. Subdivision B. So usually those from out of state that have met the triple C's, they have met an equivalent. So.
Mm-hmm. I think, and maybe Amy knows, that there is a program in Arizona that completes the didactic portion of their AUD program and graduates students, and they're left to their own devices to find their RPE experience or their fourth year externship, which would really leave them in the lurch coming to California. And they're going to have to join a program. Because as far as, I mean, I don't know, in Arizona, I guess you can do that. You don't have to be associated with a program, and you can just go get your fourth year externship. Amy, do you know anything about it?
I don't. That's fascinating. I, I don't know when during this discussion, Marcia, it's appropriate, but there may be a couple people on the call from some of the programs that might be able to shed some light if they've come across that too.
Okay, well, if there are, I'm looking at the list right now to see.
I think Jody's on and Rupa's on and
Oh, I see. And the other attendees. Okay, do we want to go to public comment for this issue? I need some guidance on doing that. Paul,
Can you repeat your question, Marcia?
I was just wondering if we want to take public comment on this issue at this point to get some input from some of the program representation here.
That's up to you. If you think that you need more information to continue with this, you most certainly can.
Sure. Okay. Can we open for public comment on this question?
We are open for public comment on agenda item 3. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of your screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. And it looks like our first comment comes from Jody Weisenberg. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you, David. Good afternoon to everybody. Dr. Raggio, would you repeat the question you're inquiring about so I make sure I answer to your satisfaction here?
Yes, we're just looking at how, have you had any students who come from another state who've either graduated from a program and have no RPE experience, no 4th year, and you're taking them in just for that purpose, or some that have partial hours toward the RPE, but not full, and you take them in to complete that? Do you have any experience with that?
Sure, happy to address that. I actually raised that question the last time you asked it of me, and I was a fledgling program at the time, but did go back to the ACDCs. We meet as a group regularly. All the directors of clinical education of all the AUD programs in California meet on a regular basis to discuss best practice and align protocols and policies so that we can stay within the guidelines of our accreditation bodies, as well as complying to the regulatory and statutes required by the board. The consensus among the people that are in that group was that we have not had anybody apply, and that we feel that it would be burdensome to the programs because we are having a hard enough time with the addition of, now we have 6 programs in the state. We're having a hard enough time finding RPE placements for our enrolled students, let alone taking in somebody from another state. I would wonder if that wouldn't be something that the person would just have to go ahead and get their ASHA-Cs or ABAs, because the board allows for reciprocity when they've gained that, and why we would want them to have to then have a 12-month in this state if they already were able to get their Cs somewhere else.
I thought that's what Cherise said, though, that they do have to meet that requirement as well. So you can't just get your Cs and come into the state. There's other requirements.
Well, there's requirements by the accreditation boards to address your question from before. The accreditation body does set certain requirements for us for hours. So the 1600 that I heard Cherise say was that was unknown to me. So that's new information. I don't know anything about that program, but the consensus among the ACBCs was that that would be pretty burdensome to accept somebody just to find them a placement.
However, it's not unheard of for you to have students from your own programs who go out of state to get RPE experience.
Actually, so that brings in NC Sarah. and our ability to place students in other states, because California doesn't participate in the consortium of NC-SARA that allows for graduate programs to put their students in other states. So what we wind up doing is we wind up actually asking that state whether or not our student being present triggers a physical presence. If it triggers a physical presence, we can't place them because we're not part of the NC-SARA consortium. A lot of students will allow that, but it wasn't my understanding that they got an RPE in California unless they were supervised by a California licensed audiologist. So I'm unsure, unless they were working in a VA where an out-of-state VA, there was a audiologist who held the California license, how they would then complete an RPE under another state's licensure.
Okay, so the story that Charisse told us is pretty unique, it sounds like.
I think so, to be honest. I never heard of it, but I mean, I don't doubt it happened, but I wouldn't think that this is commonplace or something that we deal with on a regular basis.
I mean, I suppose we should, it doesn't hurt to keep the question in the survey, just to see, just to get that information that nobody's for it. Rupa, I learned about this federal visa problem from you. Are you still, oh, I don't see your name anymore.
She had to go to another meeting.
Do you know about it?
We've been texting each other. So she had to be at another meeting. So she's no longer on the call.
Okay.
I think that initially came from Jackie Georgeson, honestly. And I don't know if UOP is still bringing in people, but I can tell you that Charisse Lands, who was the clinical director of education for UOP, was in fact herself on a visa here from Canada. And she didn't find it to be burdensome herself. And she reported that. I think our original conversation was we were really interested in maintaining the 12-month time. And your statement in the beginning of the committee meeting, Marcia, was 100% accurate. We really want to maintain the time for the RPE in California. The hours are being dictated by the accreditation bodies, not necessarily by the programs. So I would think that the board would not want to maybe go below what some of the accreditation bodies are currently requiring. But, certainly ask the question. I don't think it's as much of a problem as it might have been when it was raised a couple of years back.
Okay. We'll still ask about it just in case there's a straggler out there somewhere.
Sure. Sounds good.
Okay. Can we keep the public aspect open while we go through the rest of these things in case an issue comes up? Any problem with that?
Madam Chair, this is Michael. You can take public comment at any time. We should also take it at the end of the item.
Yes, but can I just keep it running? I don't have to close it and open it, do I?
Certainly, you can.
Okay. Moving now to question or issue number 4. Should the board remove the 3 different clinical settings requirement? I would say yes, that's outdated, that kind of thing. But I think we should ask people what they think. Jody, you have a thought?
This is the moderator. I'm requesting, I sent a
Thank
request
you.
for Jody
Yeah.
to unmute again.
Thank you, David, for unmuting me. Yeah, sorry, I was muted after the last comment. Currently, that's what we're looking at. The CAA and ACAE accreditation gives, they want to see not only experience in all the various aspects of diagnostic and treatment, but also a good experience across the age ranges. So currently I'm using the 3-person criteria, but I agree it is an antiquated rule that we have. I think what's most important is that we don't only use placements that don't give the depth and breadth of an enriched clinical experience. For example, not to place somebody in a clinical internship that maybe the only thing that practice does is interoperative monitoring. Like that wouldn't be something that the programs would do. So we're always looking to ensure that all of the rubrics that are given to us by the accreditation bodies and the mapping to our coursework as well as to our clinical practica match the depth and breadth of experience that's required by the accreditation bodies.
Which kind of leads to the next issue. Do you have a way to, I guess, log the clinical rotation experience so that you feel, I mean, you can have it on paper what is sufficient, but do you have a way to kind of prove it to yourselves that they've met these or had these experiences?
Sure. We use all of the programs use an online repository. I think even UOP has now switched to Calypso, which is standard in speech language pathology and now has been adapted to meet the accreditation requirements for a Doctor of Audiology as well. And within that, it's actually by semester. Some of our programs are still in candidacy status, so the amount of information they ask you would be blown away at how granular the questions get, down to can the student even heat their lunch at this clinical site. So it gets pretty granular. It goes over how the productivity of what the student would see during the semester, the breakdown of how many audiologists, the student to audiology ratio, the types of experiences they will have, the types of interprofessional experiences they will have. It's a pretty significant site evaluation form, as well as ongoing clinical clock hour supervisions from the preceptors and the learning sites.
Okay, so there are mechanisms, and I think we should keep in issues like logging in or knowing how many different clinical rotations there are before they feel they can do an externship. Question 7.
Yeah.
Sorry.
I wanted to comment on something you asked before, we all welcome that. We've been waiting for this survey, and we're really excited to be able to give you all the feedback that you're requesting on this. Just to relate back, we don't actually have observations in the doctoral program. Some of our programs require clinical observation prior to admission, because we want to make sure that the people know what an audiologist is and does before they apply for a doctoral program. But in most of the AUD programs, ours being probably one of the newest, they actually start on-campus patient care within the first year. So in our program, for example, I can speak to the fact that in semester 1, they are in the clinic really as part of AudAssess 1, mostly doing labs. But as soon as they go into the second semester of their first year, they're in clinic seeing patients in our clinic and being supervised by the clinic director or clinic preceptor 100% of the time.
So we definitely need to know that granular level in terms of all the programs, when they start, what they're doing, when do they begin to see patients, and do they have an observation component or not? Sounds like you don't, but we should certainly know about it to help guide us better.
And then the simulation is currently at about 10%. American Speech and Hearing, CAA, allows, I think, 10% of the clinical clock hours, and that came up during COVID. You were right, Marcia. That was what the impetus was to addressing that. But it's no more than 10%.
Okay. I'm moving on to this question. So should the board remove the allowance that 25 hours of supervised clinical rotations in a field other than audiology can be counted toward licensure? I think we should leave that question in there. It's an old one also. I see the point of it. Whether it's necessary for licensure, I think it's good educational tenet. But whether we need it for licensure, I don't know. But any thoughts about that? Any of the committee members or public members?
I can tell you that the accreditation bodies do require some hours in speech language assessment and evaluation for speech and language disorder, mostly for a normal hearing person. That is part of what we track in our clinical experiences currently for accreditation.
I know some programs just do 25 hours of observation. They're actually
Mhm.
not doing anything but observing. They're not hands-on, no hands-on element to it. So maybe we ought to ask this a little more specifically. What's the nature of it?
That makes sense.
Um, so should clinical rotation hours of the externship be tracked and reported to the board for verification? I think that's a good question. And should we distinguish whether they're telepractice or not? Are you doing any telepractice in your program, Jody?
We are not doing any telepractice in our program. The way the accreditation bodies have kind of couched telepractice is an alternative clinical experience. So that is, we can track it there if our students happen to be in the VA, which is mostly, as I'm sure Dr. White can attest to, where most of the telepractice in the state of California is actually happening.
Yeah.
So that would only be if they were in that kind of a placement. We don't offer that from our program.
Okay. For the clinical rotation hours, should the regulations limit the number of hours allowed for certain activities? That's probably is the case. Again, would like to see the response to that. For the RPE or externship, should the regulations limit the number of hours allowed for certain activities? Again, I'd like to see the input that we're going to get and the thoughts on that from the program directors. Should the regulations restrict the ability to accrue RP hours until after preliminary clinical rotations are completed? So that was an early idea that you just said, Jody, that your program they can actually start seeing patients in the second semester of year one.
Correct. Actually, we're late as compared to the other programs because we don't have as much of a robust clinic as those who have had a clinic before we opened, because we built a new clinic. Everybody else like kind of already had one.
So that would be interesting to get that information to see how many of them start supervised rotations, like from day one or from semester two or whenever, so that we're allowing. I mean, there was the notion that they're really such novices in those early rotations that we wouldn't really call it equivalent to what a 12-month RPE post-didactic would have been in terms of its character. There, it just couldn't be the same. So, and there are people who are upset about that you should finish all your classroom work and then start this experiential externship, and then it's solid. But if we start accepting things really early when people really don't know what they're doing, should that be counted?
So what I would say is we have more control over what we do in our clinic than we have once they leave and go outside.
Mm-hmm.
So to be perfectly honest with you, we know we're giving 100% supervision when they're there. Once they go into a practice or somewhere else, they may not be. I think that what we do is we do odd assessment. We all teach the didactic courses, and then when we introduce them to the clinical practice, it's based on just the diagnostic assessments that they've had didactic instruction in. I think because of the depth and breadth of the audiology doctoral program, it would be inadvisable to complete all didactic courses before you start a clinical rotation, or we'd have to have an 8-year doctoral program.
Yeah.
There's just too much. That's why we expanded from the master's degree. So I think that comment was probably from somebody who, wasn't recognizing the depth and breadth of all the didactic information that's given in a 4-year doctoral program for the CSUs at least.
Okay, so it makes for a good question, and we should keep it in the survey.
Mm-hmm.
Should the regulations clarify when an RP license is required? Yeah, I think that's also an important question. Under your AUD program supervised professional experience requirements, when I read through these, I think they're all appropriate to keep in our surveys. Anybody taking a look at those think otherwise?
No, I think they're all appropriate.
Yeah, I do too. So I think we would add all those. And our last section is your AD program supervised clinical practice requirements, clinical rotations. We worked on these pretty carefully, trying to capture the issues that we want to make sure are spell good consumer protection. And it has to do with a lot with supervision, how much supervision, how much is direct, how long are they in these rotations, just get the nuts and bolts of how they're done so we can get a sense of the quality of them. You know, when do these rotations begin? We're learning something from one program today, how early they begin.
So just to address that again, I think all of the programs, except Sacramento, because we've been out of a director of clinical education from that program for a number of years now, so we don't have insight into Sacramento, so I need to not speak for them. But the other 5 programs meet on a regular basis, and all of them institute clinical practica within the first year.
Okay, so we're going to learn that. And do you track those clinical rotations in a separate report?
They're all tracked by semester in Calypso. I guess I'd have to ask you, what do you mean by a separate report, just to make sure I'm answering you accurately?
Yeah, I mean, do you look at it differently? We're thinking of implementing this 12-month experience really spread over a long time. And how will you monitor the completion of all those things so that they end up with the time requirement necessary in the end?
Yeah, I think that, you know, some of the programs offer some more hours prior to the RPE just because of their just how they're set up. For example, the joint program between San Diego and UC, they operate a little bit differently because it's a joint program, obviously, and it's connected with a medical center, and not the other programs are not connected with a medical center, so that it's a little bit different. So asking the question is reasonable, because we're not all the same as far as that's concerned.
Okay, I'd like to ask the audiology practice committee members if they have any thoughts on additional questions, or if you think any of the current questions are irrelevant or should be modified in some way.
I think we've had a good discussion thus far, and I'd rather get more information via the survey than not enough. So I feel pretty good about having all of that in there as discussed.
I agree. Better to have too much information than not enough. Can I ask any public member if they'd like to contribute any other questions or thoughts about the survey as it stands?
We appreciate that it's coming out. The only thing I would add is that some of the programs actually have directors of clinical education that are actually, their job is basically to be able to answer every question that you've put out. Sometimes the chair or the director may or may not have insight into some of this information. So I would ask the board to consider not only sending this to the chairs of each program, but also asking that the directors of clinical education weigh in. I know that last time my program gave you some high level information, but it sounds like you're really getting granular, and I want to make sure that you get the information you're seeking.
Yeah, we want to talk to the people in the trenches.
Yep.
So I'm happy to do that. In fact, I was hoping that if we send them to the chairs, they would turn around right away and give it to the people who know the answers. But we can add that language into our request.
Yeah, there are only currently 3, just FYI. Myself at San Jose, Margaret Winters at LA in CSU LA, and Dr. Kirsch at SDSU. So currently Sacramento, UOP, and Northridge do not currently have a Director of Clinical Education position filled.
Okay, we will craft our language accordingly so that we're
Thank you.
inclusive. Is there any other public comment on the survey or this issue in general?
In the last few seconds, there have been no requests for public comment. Shall we wait just a few more seconds to see if we have a request?
Sure.
All right. For those participating, please type the word comment into the Q&A box in the lower right-hand corner of the screen if you wish to make a comment. Dial-in users, please dial *3 to raise your hand. We're going to wait just a few more seconds. Seeing no requests, would you like to return to the agenda?
Yes, please. So I don't see that we had too many modifications to the survey. It's certainly some good information that we could utilize to maybe craft our questions a little differently, but I think we really have the core of what we want to ask. So we're going to go on working with staff to develop and disseminate the questionnaire. I'm not sure, survey, what the timeline might be for that. Charisse, would you speak to that, or if you can?
Yes, when I had reached out to the department's FOLLOW program who helps with these kind of surveys, they said it could take just a few weeks to pull it all together. I think we'll just need to make sure we grab all of the appropriate clinical directors and chairs of each program off of the website. So we just make sure we send it right along to the right people. So hopefully within a month is my best guess. We should be able to get this out.
Okay, great. Okay, I would like to suggest that we take a 10-minute break before we go into the next subcommittee meeting, if everybody's in agreement with that.
Well, we have a bit to unpack today. If we could go ahead and start with getting a roll for the committee.
Absolutely. Would you like me to read it?
Sure, thanks.
Todd Borges,
Here.
Marcia Raggio,
Here?
Karen Chang,
Here.
Julio Valdez,
Here.
Amy White.
Here.
You have a quorum.
Thank you very much. If we could open up for public comment for items not on the agenda, please.
We are now taking public comment for items not on the agenda. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comments, do you wish to return to the agenda?
Please. Okay, so let's jump right into item number 3, review, discussion, and possible action on the statutes and regulations regarding hearing aid dispensing trainees, as stated in Title 16, California Code of Regulations, sections 1399.114 through 1399.119. From reading the introduction, this sounds like this has been a long time coming, Paul and Charisse.
Yes, that's correct.
It's been floating out there for quite a few years. Okay, well, there's a lot to go through here, and I have some questions in addition to the discussion questions, and I'm sure you guys may have some too. So I think what would probably be best is if we just start with the discussion questions, work through those, and then we can circle back to any questions anyone else may have outside of those 9 that are listed. Does that sound like that's good for everyone?
Is Maria here by any chance?
I am here and that works, and I can explain as we go through discussion question what changes were made in that section.
Awesome.
Do you want to give an overview or?
Yeah, like Mr. Borges said, this is a proposed, adopted proposed language the board had proposed, had adopted in 2018 that we're bringing back to prepare for regulatory, the regulatory process. And so we did look at the language, and there was some areas that I identified that needs a little bit of cleanup before it could be, before presenting it to the board or requiring the board to reapprove it in order to get it ready for the process. And so we added some sections that weren't previously there to help clean up the whole article. And specifically, section 1399.114 was added to be able to distinguish between a training applicant and a temporary license. A temporary license. So we have 2 license types for temporary license. And so distinguishing that, and in particularly a problem that I came across as I was, reviewing this was that in the event that a temporary licensee fails their exam, they end up having to be supervised. And so that caused a lot of confusion when I was looking at the supervision requirements. So that's why we're making that distinction and clearing that part up so that when we're looking at the supervision requirement, we're looking at from a perspective of not just only trainees, but also temporary license holder who have failed their exam.
Can I just clarify something about the 2 license types? One is the hearing aid dispensing trainee. The other is someone who comes from out of state with an existing license from that other state. Is that right?
Yes, that's correct. And so because the regulations, especially in this article, it specifically just focused on trainee applicant. But the problem, like I mentioned, the supervision requirement, if it's focusing on trainee applicants, it kind of leaves the temporary license holder from out of state who failed an exam. It kind of doesn't describe them. It kind of leaves them out. So that's what a lot of the changes I've made here, suggesting that should be made. It clears that, so that's very clear to what happens to those license. So let's see, and then another section. Another section I'm suggesting we add is 1399.115 to make, again, the requirements applicable to both license types that are supervised. So a lot of the changes you'll notice is that I remove a trainee applicant. So it's just like a supervisor, make it so that it's just a very neutral language.
Okay. Let's, before we get too far ahead of ourselves, let's start with question 1 for section 1399.114E. The question is whether or not that section should be removed or amended. And if amended, it may be repurposed to discuss the number of temporary license holders that can be supervised.
Yeah, so with that one, I don't know if it's necessary to say that an excessive number of trainee applicants under a supervisor may preclude finding by the board that the trainee applicant will be adequately supervised and trained. I don't know if that's necessary because we kind of go in details in a different section. So it might be best to kind of explain about situations where a supervising dispenser, if they have 3 trainee, what does that mean? Does that mean that they can't have a temporary license holder? Are they included in that number of 3 trainees? Or like, yeah, how many of those people can they also have, essentially?
Well, if we made the language neutral, would it not encompass 3 in total?
I think the clarity might come from more in specifying each section dealing with like more mutually exclusive issues. So leaving the issue about too many supervisees not ensuring adequate supervision, to move any concerns about that over to the supervisor requirements in 116.116. So that way the regulation is that regulation section is about one thing, and then all of the supervisor requirements and limitations are off in another section.
Right. Since that's a fairly vague statement,
It is, and it's not
it's easier
tied
to
the rest of
remove it. Yeah. Okay. So we're talking about removing that section in its entirety because it's actually covered in more detail farther on.
Yeah, absolutely.
Okay. Anyone have any questions about that?
I just think that's a good idea to move it to that
Mhm.
section.
Agreed.
Are we talking about moving it or eliminating it?
Oh, I thought that was a suggestion, that it would be that kind of issue, at least, would be moved to the supervisory requirements.
You're going to eliminate it from 114 and then make sure we cover that sort of concept in 116, which I
Okay, and
think some of the changes proposed really do that when you're talking about in 116 about certain criteria for supervision and the number that they can supervise, unless I'm looking at the wrong section. Oh. And we need to make sure we're doing both.
Right,
Yeah.
right. And
And I
the
think-
term excessive is too subjective.
Yeah, and I think we should be a little more neutral in 116 so that we're covering everybody.
Yeah, similar to language that we have for SLIPAs and aids.
Absolutely, where it encompasses all the types of licenses or registrations that they could be supervising.
Right. Okay.
If there aren't any questions with this section, we can move on to 115, and I don't have any suggested or recommendation changes to that. It's just, we're gonna make it neutral, so it's applicable to both license type.
In regards to 115A, where it says the board may refuse to approve or approve subject to terms and conditions, should that not be broken out with commas? Approve, comma, subject to terms and conditions, comma. A hearing aid dispenser's authority to supervise and may suspend, revoke, or impose probationary conditions on a hearing aids dispenser's authority.
I am not the grammarian, but I feel like there's a comma after the or, so if the board may refuse to approve, before the or approve subject to terms and conditions, I think
Yep.
that way.
Okay. And just to throw a little bit of a wrench in it, just because it's here in this section, we're all happy with the trainees having 3 years of experience. We all feel that that's a good number, that that's long enough to have enough knowledge to be able to take someone on to train them, potentially multiple people.
Do you know if that matches the requirement to serve as an SME
I don't know that.
or to be an examiner?
I thought examiner was 5, to be honest, but I don't remember. It's been a long time. That's something we'd have to look up, I guess.
Does somebody know?
I'm looking it up now.
Sharice is looking that up.
Do we have that requirement? I know we just went through the audiology one. Do we have that such a requirement for audiology or speech language pathology?
Yeah, we have for SLIPAs, we recently looked at that one. For SLIPAs, they have to have 2 years of experience after their initial licensure.
And currently, to be a subject matter expert for either the exam workshops or the dispensing practical exam, you have to have 3 or more.
Okay.
So then I would agree.
Anyone
I
that
think
has
3.
only 3 years, but that is the limit.
Okay. Well, if it matches that, then that's fine. I personally think 2 or 3 is not enough to know enough, but having it match the SME is, I think, appropriate.
Yeah, I don't disagree, Todd, but having it be consistent,
Yep.
seems to make the most sense.
Yep, I agree with you.
I agree with that too.
Okay. So do we want to move on to 116?
Yeah, with 116, I think the only question I have is in item C. So the board had at their last meeting approved to limit the number of trainees to be supervised as 3, and kind of clean up the language so that it's 3 consecutive years of experience, and then disciplinary actions and things like that. But the reason why they're highlighted is because I had moved it around from what the board previously approved, which is attachment B. Because what we like to do is we like to use the language that's already there instead of creating new language. So that's what I did. Yeah, so that's why it's highlighted, because I just rearranged it so I could keep as much of the original language intact, to still meet your what the board approved. And my only questions for this one would be if we need to specify an effective date, because it says effective 1 year. I don't know if that's is that something we could do as part of the regulatory process, or if we're going to be required to say how many years or specify an actual date. So I think Karen might be able to provide more feedback, because I think the beginning 1 year might be vague, and I don't know if Office of Administrative Law is going to like that. And then another regarding to the record keeping, if the board wishes to have a different record keeping of the certificate than what it is for regular CE requirements. And I provided in the memo the requirements for other license types.
And you're talking about keeping the records of essentially their
certificate of completion?
Their certificate of completion for the supervision CEUs, essentially, that they have to do.
Correct.
Okay. I have a question about that. Where are they getting that training? What courses are available for them to be able to complete this very specific supervision training?
So I believe it's a requirement. I'm not sure. I'll have to look at the language, but I think for SLIPA, if you're supervising, I think that is a requirement. And RPEs, so speech language pathologists and audiologists, there are supervision courses available. And I don't think they're going to be specific. I think it's just how to supervise and, what good supervision is and how to educate and communicate. That's what supervision trainings are like.
Those are under CPD approved providers though, so it is a little different than your CE courses that are approved. We would have to go look at CE courses for hearing aid dispensers to see if there are enough supervision ones, or if somebody's willing to step up and start providing those.
And when you say look to see if they're there, you're talking about Audiology Online. Where are we looking? Okay.
Normal providers, those that apply to the board to get approval for CE courses for hearing aids.
Right. Well, right now, as of this month, there are 0. There are a few for audiologists when you type in the keyword supervision, but they're audiologist specific. They're not general. They're not general courses.
Those were there because audiology didn't have any of those until it was a requirement. So
Yeah.
that means that the professional organizations stepped up when they saw that the requirement was there and created the courses within their annual conferences.
So then do we need to give some type of a grace period for the professional organizations to come up with these courses for hearing aid dispensers?
Does this 1 year after the effective date of the regulations count for that?
Hi, this is Paul, and I think, Todd, you bring up a valid point here, but I do think that this is maybe an opportunity for the board to conduct some outreach with organizations and identify this need, because I know in the past, the board has had this need, and as Dr. Rajo just stated, organizations do step up and will step up. It's an opportunity for them to expand what they offer, and an opportunity for licensees to take advantage of this kind of training. So I have talked to individuals in the other professions who are willing to provide various types of specific training that's needed. I think this may be an opportunity for us to work together and maybe do some outreach with some organizations, including some of the ones you've identified.
And that's the beginning of the 1 year. That's the grace period we're referring to, essentially. In essence,
Or
they
it
have
could be
they have a
longer.
year to put it together.
Or it could be, right, it could be, I think a specified time based on whatever the need is.
Okay.
I think in experience from big changes at other boards, there's often been sometimes a delayed implementation for things that have such a big consequence. So, it's not effective immediately. That coming within a year or two, and you specify in the regulation when it becomes effective.
And since we're the course provider approvers, then we can certainly, speed up the process as much as possible once we have content.
I thought the usual expectation was a couple of years for regulations to actually come to fruition. And is that true, that timeline?
Yeah, it takes a couple of years to process. I'm not quite sure how long it is when it becomes effective. So that's the effective date, depending on the effective date. If we want a delayed implementation, I believe we need to state that in the regulations.
But if it takes 2 years to do that and another year after they become effective, that does give them a good amount of time to develop these courses. If they know about it now, as Paul said,
Right.
creating some outreach for that.
To keep it in mind, right now, this is at the committee level. It still has to go to the board. And then, of course, it would start that process. So about a year before or more before it might be noticed. And then the board has a year to take comment, make adjustments, so on and so forth, to get it back to OAL before it has to be either reviewed and approved or withdrawn. And then, of course, then it becomes effective at the next, I think it's like each quarter, right? So there is a pretty good lead time just to get through the regulatory process. And the option, of course, is always to specify the 1 year after, or to pick a date, and then we keep revising it to make sure it's always a year after the promulgation of the regulation. So that's always an option as well.
So lots of time.
Lots of time.
Yeah,
Okay.
and just doing a quick audit here, Todd, on Audiology Online, there are a couple courses that are very general. It's like how to supervise all sorts of staff and students and mentees, et cetera, where it's not specific to audiology or speech language pathology. So I think there's also some of those courses that already exist even on the online opportunities.
Just one more thing that then you guys have to be aware of to make sure that those courses are being approved for hearing aid dispensers, or that outreach that those individuals that are creating those courses know to ask for hearing aid dispenser credit as well, not just audiology.
Exactly.
I wonder if I don't know how Audiology Online works in terms of how they decide on what course offerings they're going to have, but if they're aware of this, they may develop courses specifically for hearing aid dispensers, I presume.
I do think when we talk about this at the board level, we will probably have somebody from Audiology Online and hearing the discussions and engaging with them. And we can definitely try to reach out to the two women that have been on prior meetings when we discussed CPD and CE requirements, so that we're kind of starting that dialogue early.
Good. Okay.
Usually they're on.
Thank you. Okay. Any other questions or comments about this section?
For this section, I think we were talking about the language that we had removed from the first section, maybe incorporating that, or if that's making sure that's covered in here. So the language, the language we had removed in the first section is an excessive
Right.
number of trainee applicants under a supervisor may preclude a finding by the board that the trainee applicant will be adequately supervised and trained. And I think what was discussed was removing trainee applicant from maybe B. So it's just 3 supervised no more than 3.
Trainee applicants or temporary licensees at any one time.
So we're looking at for B in 116 to say 3 trainee applicants or temporary license holder or licensee at any one time.
And the number 3, that's consistent with the audiology, with the SLPAs?
No, for SLPAs, we had changed it to no more than 3 full-times or 3 full-times, no more than 6 at any one time to count for full-time and part-time people. The discussion here was to limit, previous discussion was to limit, well, it has always been 3. Originally it was at 1,
Yeah.
up to 3, but we're just now specifying just 3.
Let me just make a clarification. It's currently the limit is 1. You can request an exemption or a waiver to supervise more than 1. But the limit is 1, and at the last discussion of this regulation, the committee agreed to extend that to 3 under certain conditions.
What are those conditions?
They're listed. They're listed here.
If they meet the criteria.
Right.
Oh.
The requirements that are listed.
Okay, the following criteria. Okay. Well, that's the criteria that's listed there under Section A is just saying why the criteria for allowing someone to be a supervising dispenser. I thought you were saying there was criteria for allowing them to have 3 instead of 1.
Right. I think in the discussion, the committee, and I'm having to go back a few years here, but the committee said as long as the supervisor meets this requirement, the committee was willing to allow them to supervise up to 3 individuals instead of the way it was written before, where it was an allowance of 1, and then you had to get a waiver to supervise more.
Yes, so the current language says a licensed hearing aid dispenser shall not supervise more than 1 applicant, trainee applicants at any one time, or unless a specific waiver has been granted by the board. Criteria for such waiver shall be, and it lists the 3 criteria we have in currently the license for 3 years, no disciplinary actions, and violations of regulations. And then B was originally a licensed hearing aid dispenser shall not in any circumstance supervise more than 3 trainee applicants at any one time. So what the board did was wanted to combine B and A.
Okay.
Yeah.
And is everyone else happy with 3 going from 1 to 3? I don't know how happy I am about it, but I'm curious what everyone else's thoughts are on that.
Todd, do you have any sense of how many trainees a given dispenser might have?
1,
Typically one.
typically 1. I mean, part of it is, I think, just because lack of people, for the position.
Mhm.
But, what happens if that person fails their exam and now they have to be what was called 100%, supervised, now immediate supervision? How can I possibly supervise the other 2 even partially if I have to be over the shoulder of this person 100% of the time?
Yeah, that would be hard.
I would think it would be impossible.
Yeah.
As many slices of the pie I cut up, I got a smaller piece of pie.
Unless they're just part-time, maybe as a trainee, they're only coming in 1 or 2
Yep.
days a week while they work on getting their license because they work other jobs or something while they're in the process.
So
Possibility.
currently now it's going to say 1 but you can appeal for up to 3. Is that what it's going to say?
No, it's saying you can do 3. You don't have to do the waiver anymore, right, Paul? Because we're saying you can do up to 3, and they're eliminating the waiver thing.
That is correct. And I think that, it's up to this committee to make that determination and, you can entertain, recommending that we go back to, or that we keep it as is, but maybe set some criteria and nail down what that criteria is for a waiver, or, it's really up to this committee to make that recommendation.
I'm curious if the committee would want to specify criteria to ensure adequate supervision and training of the trainees, that there might be some sort of clause that that limits it below 3. So, like you said, if you have a trainee applicant or temporary license holder that has failed the examination, that is that's under your supervision, that the number of trainees you can hold has to go down or something along those lines. Or even something to the effect that you can, you can't supervise more than 3, but in order to ensure adequate supervision and training, any hearing aid dispenser may be limited to 2 or 1 trainee if they are unable to meet their supervision requirements and training requirements in 0.118 and 0.119. So it kind of loops you back into what do we want you to be training and doing, and what about the levels of supervision are you upholding? And if the board finds that you're inadequately doing so, we would limit you back down.
And I think this committee would have to consider the scenario in which you have 3 trainees and say 1 or 2 of them fail the exam. Then what do? You still have the 3 trainees to deal with, and only 1 of you and 2 people that need 100% supervision. I think that's why the code was always written as a one-on-one situation with exceptions.
That seems cleaner to me to stick to that.
Yeah, I much prefer that because it's a case by case. You can look and see what's going on with that 1 trainee before you say, yeah, you can take on a second one. Like, okay, they passed the written exam, so they're getting ready for their practical. Okay, you can bring on a second one, kind of a thing. But yeah, I'm not a fan at all of, someone just starting to bring in, a bunch of trainees.
Now, my curiosity being, in regulations being too broad or too vague is always a problem. I'm curious if we might want to develop the criteria in there. It's no more than 1 trainee applicant or temporary license holder that has not passed the written examination. You know what I mean? Specifying that Is that too much?
Can
So
we
that there's
just leave it to
criteria?
the discretion of board staff to determine if more can be?
I generally love that. I just worry about once we get to the
I think
attorneys reviewing everything that
Well,
we're not
that was the
clear enough,
language
and then we
before,
have to
though.
come back to you to ask you the question again.
Sounds like
That was the language before, though, and it passed muster. So
they want to maintain.
Oh, so just change it back to one.
Yeah, one with the option of.
Knowing it was language that OAL approved in previous years does not really help you. There is a new director at the Office of Administrative Law, and they have raised and changed some of the standards that they will approve.
But Karen, if we're not changing anything and we leave it as is, then there's no issue, right?
If you don't, well, it depends on who the reviewer is. I mean, if you don't change anything in a regulation section, right, you're fine. If you change to non-gendered language, which doing any change within the section is considered opening the section to some reviewers. Other reviewers, you're like, well, that's over in A, and we're only correcting what's in C. Leave it alone. I've had things move through that way, but I'm told there are one or two that once you open a section, they're going to question the language and try to bring it up to what the standards are now. So, you know, we do the best we can. We go forward and hope that it's not a problem.
Yeah,
we
it
roll the
wouldn't
dice,
seem-
and then if we
it wouldn't
need to,
seem
we
like-
can come back and revisit it.
Yeah.
Right, I don't think it'd be a good use of our time to anticipate that and then go in here and try to
Right.
predict what they might think.
Yeah, so I'll clean the language up and then, yeah, we could hold on, taking any action and bring this back to another hearing so that we can revisit, this language with a clearer version of it, to make sure like that's what the board intends on the requirements. Yeah, but it sounds like, we want to kind of revert back to the current requirements,
Pre-2018.
to the original language. And then maybe kind of, it looks like from the original language, we might want to clean it up when it comes to the following criteria. Because it's my understanding that the following criteria is applicable as to be a supervisor, not to be a supervisor for more than 3 people. So that's probably where it needs to be cleaned. But it's really hard to tell with the crossouts and stuff like that at the moment. So, yeah, so I have noted kind of the discussion where the board wants to move forward and can provide a cleaner version.
Is everyone comfortable with that? Basically keeping that section as it is with just one.
Yes.
Okay.
Yes.
Yes.
Could we take a moment and open for public comment for this section and the 2 or 3 sections we've gone through already? Just so we don't lose anyone.
Absolutely. We're now open for public comment on the last 3 sections of 3. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no requests for public comment, do you wish to return to the agenda?
Please.
Since there aren't any questions, I guess we can proceed to question number 4, which is on section 117. Should section 1399.117 be amended or repealed? So again, I went through all the sections for temporary license and tried to make applicable to both, and that's what I did in this section. As I was reading it, I wasn't sure if this section is necessary, as it doesn't really specify anything more than what's in statute. So we can repeal it if that's a desire of the board, or we can also amend it so it's applicable to both. So that was just my only suggestion when it comes to this one. And Karen, if you're there, I guess, yeah, this could be more questions towards you.
I'm trying to follow. I have the memo and I'm in the regulation, but when you're saying question number 4.
Oh, it's in the memo on page 2, the question.
So the 4th dot about limitations or caps on professional experience?
Actually, it's about whether 1399.117 should be amended or repealed.
It's one sentence that says, don't present yourself as anything but what you are, and don't refer to yourself in ads. I mean, it encourages people not to falsely advertise. I don't see why. And I guess if you've never had anybody, if you have no discipline on this, if you've had nobody violate it, it doesn't seem to be such a useful regulation. But I don't see really why you'd repeal it. You still want people to not, misrepresent themselves.
I thought the issue was simply adding the category, the other license type was simply, isn't that right, Maria? That's
Well, there's two way that I see this happening is that we can amend it to make it applicable. But usually my understanding for regulations is that it specifies what's in statute, and from reading that language, it doesn't really make any statute, like in statutes, it does say that like a lot of this language comes from statute. So there's nothing more we're adding to that language. Yeah, we're not clarifying anything, so we can repeal it instead of amending it.
Okay.
And I know
still don't get an answer to that, my question. I thought you said, Maria, that we were, if you look at the current language in yellow here, that you're adding the temporary license holder to the language. Is that not the purpose?
yes, that I'm just saying there's two approaches. We can amend it to include that temporary license holder, or because it doesn't clarify statutes, we can just repeal the whole section.
Meaning just get rid of it in its entirety.
Yes, and I think also, I think a lot of this is also covered in the advertisement regulations, which I think we're looking at today.
Yeah.
So I think that's why I'm just saying it's like we're adding extra space to our regulatory language because it's already covered somewhere else, or it's just restating what's in statute.
This is Paul, we're talking about, when you say it's covered somewhere else, are you talking about in our proposed advertising guidelines and the examples that are given today, or what we're proposing?
What's already in there. So like the tables and things like that, it's already in there.
So I think those are examples of proper advertising. And I think this would be a little bit different because this is a statement. And I know that when we're dealing with disciplinary actions, it is helpful to be able to cite a code. I think that I think it may be helpful to actually stay in there and state it specifically that a person who's a trainee or holds a temporary license cannot hold themselves out to be a licensee, right? That's what it's saying, or that they have to make sure that the consumer knows that they're a temporary license holder.
I think it might be helpful to, for those purposes, Paul, to be able to look to this language. I wouldn't want any misinterpretation that, well, I'm a temporary license holder, not a trainee applicant, so therefore this doesn't apply to me.
I can see where it would be helpful from an enforcement standpoint.
Yeah, I'm for just keeping it in as it is, as you did it, and just adding the temporary license holder so it clarifies both types of individuals.
Okay, well, yeah, we'll do the amendments then. We'll go with that. If there are no questions to 117, we can go to 118. I don't have any comments or feedback on there.
Actually, I do.
All right.
On 118 C6, where it says masking for pure tones and speech testing. Should that not say pure tone, air, and bone? We're specifying in number 1, pure tone, air and bone conduction audiometry. And then we're saying masking for pure tones. And that could lead someone to maybe say, oh, pure tone, you mean just air? Or, I don't know why we wouldn't just be specific there if we're specific farther up.
I think that's a good suggestion.
Thank you. Yeah, we've noted that as the changes to that term. So it'll be pure tone, air and bone, and speech testing.
Yeah.
Does it need the conduction audiometry or no?
Say again? Is it what?
Oh,
Does
no.
it need the conduction audiometry?
After air and bone, she's saying. Does it need to say pure tone, air and bone
Conduction.
conduction?
Oh,
No. I don't think so. I think air and bone is
if you want
self-explanatory.
continuity, I guess it should.
Yeah.
Yeah, if it said that earlier, I would keep it the same.
Yeah.
I mean, we could break down speech testing into SRT and word recognition also, if we wanted to be specific. As long as
They
it's
mention speech recognition on
Yes.
number 2,
Mhm.
and then they say speech testing in number 6. So what speech testing is that? I assume that would then be word rec, right? If they already
Word
said
rec
speech.
is number 4.
Okay, then.
But you have to.
Oh, no, masking for speech testing. Yeah. So, well, yeah. Yeah.
So are we looking at replacing speech testing and specifying speech recognition threshold, word recognition?
Yes.
Yep.
To be specific, yeah, speech recognition threshold and word recognition.
Yep. If we're going to specify what the pure tones, we should specify the speech testing as well.
Are there other items that should be listed?
Well, I have a little bit of an issue with number 10, including real ear measurement in the list, because not everyone has a real ear measurement machine, nor do they have the wherewithal to spend, $10,000-$15,000 to get one. So including that on a list that says at least, that then says, okay, you have to do this.
It does say knowledge of, as opposed to,
Well,
wouldn't hurt that they have knowledge of.
I don't know how you can I guess you can take a course, but without having the equipment to actually practice on, I don't know how worthwhile that is.
But it's best practice now to do real ear.
Yeah, but
So they should definitely have knowledge of it. However they gain that. Yes, it would be best if they could actually practice it. But if they can't, it's better to have some knowledge than none.
well, I just question how much actual knowledge they really have taken a 1-hour audiology online course and, answering 5 questions as opposed to actually doing it. I realize it's best practice, but.
So, I mean, I don't see the logic in ignoring it, or just because it's not, they can't practice it or eliminating it. If it said that you had to practice it, then that's another matter, but it just says knowledge of.
Yeah, I guess since it just says knowledge, it allows you to take a couple classes and then you have knowledge of it.
Yeah.
You know what's out there.
Mm-hmm. And what
and you should be doing it.
Yes.
Even if you're not.
Mm-hmm. Lots of people have the equipment, still don't do it.
Well, that's true. That's very true. That's very true. They're very expensive paperweights.
Mm-hmm.
Okay, I can live with that since it kind of gives them the out of just knowledge. You don't have to actually show how to do it practically. You just have to, can identify it on a piece of paper.
And I think especially now, Todd, that it's built into it's more and more frequently built into the hearing aid manufacture software to do auto REM, in conjunction with the equipment. So it's becoming, much more prevalent, even just in the software itself for the hearing aid fittings.
Yep, I'm good with that.
Are there, does anyone else have any questions on the list of items?
Actually, one other thing then, since we're talking about it, number 7, electroacoustic analysis equipment. I think we should add in the words knowledge of then of that too, since people may not have that equipment, but they should have knowledge of that equipment. As opposed to the way it's listed now, it's basically saying you have to be able to use that equipment, not just know about it.
I mean, that electroacoustic analysis is an essential piece of any practice, I would say. And, when
Well,
people come in with complaints that are hard to quantify by patient description,
well,
electroacoustic analysis is really helpful in trying to see what the problem is.
it is, but again, not everyone has a fry box.
They should have one.
Well, they should, but some of these smaller practices may not. And again, we're essentially creating a barrier by saying you got to get this equipment the way it's written.
This says, God, I'd hate to think that a trainee would not have access to that information by practice. That's
Well, I think it's, this leads us down a road of a lot more questions, and I don't know when it's appropriate to address. Should a trainee have hands-on experience with electroacoustic analysis as well as RealEar equipment? Yes, they should. Should it be required that to train someone, you have to have that equipment? If you're going to have a small practice but not have that equipment, is it appropriate to have a trainee when you cannot provide them with the tools to learn all of the aspects that are required to to follow best practices in fitting a hearing aid? So I guess it depends on what our goal is. Is our goal that the trainees have a more well-rounded opportunity to access all of that equipment so they can learn all of it, or is that not important, right?
Well, you're saying that they don't have to have the RealEar measurement; they just have to have knowledge of it.
I'm not. I kind of disagree with that. I mean, I think it depends on what our goal is, right? So I understand that on the dispensing exams and things like that, we're not, a knowledge of those items is important, on the written exams, et cetera. Do we mind that a trainee whose only hands-on education is coming from one location, is it important that they have access to electroacoustic analysis and RealEar, or is it not? And if it's not, then okay, knowledge of would be appropriate. But if we feel it is important, then we do want them to actually be able to access that equipment and put their hands on it and learn how to use it, right?
Well, yeah, but again, we're making that decision now, right? We're splitting hairs. We're going to decide, okay, we'll allow it for one, but not the other.
I don't see electroacoustic analysis and RealEar as equivalent. I think electroacoustic analysis is essential to the job of hearing aid dispensing. RealEar is a nice luxury. We have functional gain that we could do in substitution for that. Not the best substitution, not arguing that, but we have something else we could do with our existing equipment. Electroacoustic analysis, not so much. And if you look at number 11, it says hearing aid troubleshooting. Electroacoustic analysis is essential to hearing aid troubleshooting.
Especially if it's
yes,
only
we
one
could all
side,
say,
I
oh,
would
you're having
agree.
trouble, let me just send it into the manufacturer. We don't need to know anything else. We could handle it that way, but I don't think that's good practice.
But it's also not good practice to not do RealEar, and I recognize that we don't have this in the audiology side either. So I don't know, Marcia, how far down the road to go, but it is considered a standard of care now to do RealEar, and the fact, and we don't require it. We're not requiring it in states to practice, and other states do. I don't know. It gets murky.
I'm sorry, someone else had a comment.
I had a quick question for the committee actually on whether or not, since it kind of seems to go back and forth, whether or not this list should be broken down into two sections that are knowledge of items and experience doing items. So that kind of sets that minimum training level there.
Well, really, on the whole list, there's only two things that you would break out from that, and that's
Okay.
the electroacoustic and the real air measurement.
Okay, so everything else is experience doing these things.
Yeah, everything else is practical, what you would do in the office on a daily basis. And I would argue that would be real air measurement too. But I'm of the mind, yeah, it would be great that everyone should do real air measurement. Yes, everyone should have a fry box so they can do an electrical acoustic analysis of the hearing aid, determine what's wrong before they send it in for repair.
Well, that isn't always the
But
case.
not everyone necessarily. But I'm just saying that we're gonna, by having these set up the way it is, we are, and if we're okay with that, if we're okay with saying, you know what, this is just going to keep some people from being able to train individuals, then okay. But that's potentially that this is what we're saying. We're going to draw a line in the sand and say, okay, you can learn about real air, but you have to have the equipment in your office to be able to train someone on it in order to have a trainee.
I'm with you, Todd. I think it's one or both. I mean, it's either none or both. Either we say knowledge of electroacoustic analysis and real air measures is enough for us, or it's not, and that both need to have hands-on access to those pieces of equipment. And by doing that, we are holding those who want to take on trainees to a higher standard, than the rest of the dispensers at large, or dispensing audiologists at large, because it's
right.
We don't require them to have that to dispense hearing aids. But given that trainees for dispensers aren't going to graduate school and aren't forced to learn all these things in school, is it appropriate to say, yes, there is a higher standard? If you're going to train someone, they need to have access to these tools that should be used in practice of fitting hearing aids.
Well, but then that begets the question of, should we hold someone to a higher standard in training than what we require someone to practice? Or should
Right,
we just hold them to the same standard of what we have someone who is actually in practice?
Right. And I mean, we do on the, at least on the audiology side, the standards, the minimum standards required, are much different than the standards that are required for education. So.
Well, but
I don't know the right or wrong answer to that, Todd, but I agree it's different.
Yeah, I don't think the two are apples and apples, though, because they're very different length of time and educational requirements and things that I don't think you can necessarily equate one with the other in training standards.
So it does sound like that it's maybe moving more towards knowledge of for both then.
I'll dissent on that.
I would like to hear from some of the other board members.
I would dissent. I think if they're only getting training in one place, this place should provide all possible resources and access to, because otherwise it's not the same just hearing it or watching a YouTube video or just learning it if you don't have access to use it and practice on it. It's this is the time where they're learning and then they go into practice. In practice is different. Same happens in medicine. You train at an academic center where you have all the things and you're exposed to everything, and then you can go and practice and you decide. But during the training, it's important to be familiar and learn everything possible.
So then are you comfortable with, say, knowledge of the real ear measurement, or do you think that should be changed to actually working with the equipment?
Working with equipment.
So you think both of them should be changed to working with the equipment?
Only the second one.
The second one. Okay.
Most modern equipment contains both electroacoustic analysis and real ear in the same equipment.
Right.
So it's not a matter of spending $10,000 for twice for two different things. They're all in one.
Well, that's why if you don't have real ear measurement, you probably don't also have the fry box component.
Unless you have an old, a
A
real
really old one, yeah.
fry isn't even around anymore.
Right.
So maybe then could we combine
I'm
the two?
just aging myself, but I mean, yes, I mean you're right. If you're going to get one, you're automatically getting the other, and that's kind of my point, because if they don't have real ear measurement, then they probably don't have the electroacoustic analysis equipment either.
Mm-hmm.
So
I don't think we can make the argument that, well, they're expensive. It's a small practice. We shouldn't burden them with that expense. But you know, you could buy a portable audiometer to test hearing that doesn't have a masking circuit. Is that okay? No, you think masking is an essential part of the practice.
Mm-hmm.
So
well, masking is also part of the FDA requirements. So yeah, that's a whole other issue.
But electroacoustic analysis, I think, is, you know, essential to the job. So if you have to make payments on equipment or do other things to make it happen, that's good practice to have that equipment.
Can I ask a silly question as a staff member?
Yes.
So is it possible that if you were in, said small hearing aid dispenser office and hey, I'm a supervisor and I know these two are the items that I don't have them in my office. So I'm going to reach out to my fellow hearing aid dispenser, down the way and have the training done over there, like so that there's kind of a pooling of resources or a course where they can go do this. Is there anything like that potentially where they're still making a training plan and training that consists of these things? It just may not be happening in that one office. Is that potentially an alternative?
Well, then you would argue that that office isn't following, procedure. I mean, if you aren't using EAA or real ear, then you're not using it. And so that trainee is not learning, how to use it, when to use it, if they're just going to go float down there and do a hands-on training for a couple of hours with someone else. I don't know that it would be that valuable.
Not being a professional, I wasn't quite sure if this is something you can go learn how to do it somewhere else and then come back or what?
Well, it would be kind of hard because then you're basically asking that other person to train your trainee, and that person can't, right? Because they're not listed as their supervisor, right?
Supervisors running this practice, it's their practice.
Yeah.
They should have that equipment just to be this professional they are, not let alone supervising somebody else or training somebody else.
I'm with you, and I really appreciate the way Dr. Valdez, presented it. This is the only opportunity for these individuals to receive training, and I think the only place where I maybe diverge from you, Dr. Raggio, is I feel if we're going to say you need EAA, then you also need real ear. Again, knowing that most of the time those components go together. It's one singular piece of equipment in most cases. But if we are going to state that the EAA is required, I think the real ear equipment should be required as well.
Okay, I don't disagree with that. I mean, if we have to say that to get the EAA, then okay. We have to have both.
Karen Chang, are you there?
I'm here. My thought is, if current hearing aid dispensers don't need to use the real ear or the other, what's it called?
The electroacoustic equipment.
Yeah, the electroacoustic equipment. Then why are we putting a higher standard on a trainee?
Because they're not required to show competency with it during the practical exam. Is that what you're referring to?
I guess it's just
Or just in general, if me
general.
as a dispenser, I don't have to do that in my practice per
Yeah,
se,
yeah,
then
you don't have
why
to do that
should
here,
I
but
have
why
to?
Well-
should you train a trainee to do in your practice? If a trainee goes out, they're gonna practice too, and technically they don't have to do a real ear or a electroacoustic.
Right.
Well,
That's
there's
why
a
I
flaw
said
in the
front box.
premise there, Karen.
Huh?
Right. There's a flaw in that premise that they don't have to learn those things. They do have to learn those things. Somebody who's doing a hearing aid dispensing for a living and troubleshooting hearing aids, that's the nature of their business. They do have to know how to do those things, and they do have to do it.
So do we require it?
Okay,
Well,
well,
our requirements have to do with minimal competence, right? And the state exam has to do with minimal competency, that someone is minimally competent. And I don't think that we want someone being trained for a profession to be trained to minimal competence as opposed to best practice, right?
That's always
well,
been
what's the purpose of the training? The purpose of the training is for them to get their license.
Yeah, but it's not for them to be minimally
So
competent.
I know,
You don't-
I'm just saying the reason that, if I were to take on a trainee, it's to help them get their license. So
I hope it's for you to help them become an excellent hearing aid dispensing professional, not just for them to get their license. There's a difference because again, we're talking about minimal competence, or being an excellent provider of care for your clients who walk through your door. And you want the latter, when you're training someone, you want to train them to that, not to minimal competence.
So here's one of my thoughts. Completely not with this, but when I look at any of the government rules, that's my lowest barometer. This is like this is my minimal competence. This is my minimal thing that I have to do to pass. And once I get this, then it's fine. So if we want our if we want our trainees to have a minimal competence of electroacoustic and knowledge, then we should have our real ear. Then we should have they should know this stuff. Do you kind of get it? Or
yeah, but then the question comes to, do we require them to actually work on it, or do we just require them to have knowledge of it?
I think Amy, Marcia, and is in the side of working knowledge, or in the side of like knowing how to use it, correct?
Yes.
Well, that means hands-on, though. It's
Yeah,
not
that
just
hands-on.
knowledge of.
Hands-on. And so that's in my opinion, then if we're the government, then that's our minimal competence.
I see where you're going, Karen, and I don't disagree at all. I believe, given how best practices have developed in the last couple of decades, that some of these minimal requirements should be adjusted to include these things. They aren't right now, and so I see what you're saying. It's not consistent, if we require it of the trainee, but then it's not required of the practitioner. I guess my feeling is, because this is the only trainee opportunity, this is where they're being educated for their field of practice. It just would be a shame to not require that. It would be a shame to not give them the opportunity to learn those items during their trainee.
Yeah, then we should require it. If that's what we want them to do, then that's our minimal. Anything above that is above and beyond. Just an example, when my kids were babies, I looked at the CDC requirement, like what a child should do at 6 months, 5 months, whatever. That was my minimal barometer. If my child did that, then I passed. If I didn't, then it's like a no pass. So what is our government's minimal, what do we want minimally? If we want minimally to them to have to hands-on to do the electroacoustic and the real ear, then we should put that. That's my only thing. Any technical I don't even know what a real ear is. I don't even know what electroacoustic is, but any technical aspect, I don't know. But if that's our minimal standard, what we feel, then we should put that. put that in and not just knowledge of. And if I mean, other hearing aid dispensers that are now, they're just, you know, grandfathered in, right? They don't have it. They're kind of just grandfathered in.
Right. And so I agree with all of that. I don't know with the confines of this conversation or how we look to make those changes in the future, if that's something the board wants to consider in the future.
So what we're looking at just is when I'm training someone, this is the minimal things that I have to be able to do. I am fine with knowledge of, but I think requiring that they actually physically work on the equipment when there are a lot of clinics out there that don't have the equipment, I think creates
It's not
a real.
okay, Todd, that there's lots of clinics out there that don't have them. That's not okay. That's not a way to run a practice, a business of this,
Agreed.
of
And then
this
the
sort.
Can I
yeah,
just comment? This is Paul. I just wanted to point out, I know we've used different terms, minimum competence, minimum standard, and I do think that we are looking at a minimum standard practice here, and we provide the exam to ensure that a person who is going to fit and sell hearing aids can do it safely. So that exam is based on experts coming together, talking about the minimum standards, the current practices, and then those standards are put into the format of an examination. I do think we have to be careful when we start talking about best practices or we start talking about standards that go above that, because keep in mind that an individual can come in off the streets and take this exam without any training. So what we're trying to do here, I think the purpose of the trainee is to prepare people to take the exam and provide them with the training that's needed so that they're ready to take the exam. I do think that an individual who owns a practice, if they want to go above that and make sure that their training has a gold standard, then that's their prerogative and they should do that. But unfortunately, we cannot impose gold standards or higher standards than that. We impose minimum standards. I just wanted to point that out in your discussions, and when you come up with recommendations, keep that in mind, because that's what the board will be making their determination on, and that's what we will have to get by the Office of Administrative Law.
But I would argue that both of these have to do with the safety, and they are in the written portion of the exam. So provided they're in the written portion of the exam and you have to be able to answer those questions about those items, is it not then still appropriate here?
To have knowledge of the equipment, yes.
I'm not saying not to put those things into the recommendation for the regulation. All I'm saying is that whatever we put in there, if we know that if it's part of the written exam and it's part of the minimum standard, then it belongs in the regulation. If it's not, then it doesn't. That's a criteria that we should be looking at.
And again, the written exam is the knowledge-based test where you're doing the computerized test, and the practical is the hands-on. So I don't think we're demonstrating the real ear or the other.
No.
Well, no, but we also don't demonstrate hearing aid fitting at all in the practical exam. So, but to answer knowledge-based questions about electroacoustic analysis or real ear measures isn't such that you usually can just go and take a 1-hour course. It's such that you need to work with it on a regular basis to understand what those things are measuring and what they actually can or can't do in order to answer the questions on that written exam.
Number 7 says, and essential American National Standards Institute standards. That means that when hearing aids come into your office, you have to make sure that they meet those standards before you can dispense them. And the only way to know for sure is to do an electroacoustic analysis. Now, all hearing aids come with those already done at the manufacturer, but hearing aids go through a lot of travel between the manufacturer and your office, and many changes can take place. So we have to do an electroacoustic analysis in order to know that you've met those standards. So I think that's fundamental. Also, a patient comes in after 2 years of wearing their hearing aids and say, my hearing aid seems to be low. Well, is it a matter of the hearing aid malfunctioning, or is the patient's hearing has gotten worse? The only way to know that is to test their hearing and do an electroacoustic analysis to determine what the problem is. So it isn't a matter of just, oh, let me have that and send it into the manufacturer. So I say it's very fundamental, it's very basic to any practice, and it's not a gold standard, it's a basic standard.
As is verifying that the sound pressure level at the eardrum isn't going to damage the person's hearing and cause a hearing loss because we are over amplifying them due to their ear canal size and not knowing that when we don't do real ear.
Absolutely, and dispensers are able to fit children.
Dispensers aren't able to fit children.
I think they can.
Well, if they're, I guess if it's signed off by an ENT and an audiologist, but
Yeah,
it's
but they
okay.
can.
Theoretically they can, yes.
Right. In which case we can never guess the size of the ear canal and never actually know the sound pressure level and never actually know the damage being done if we're not performing real ear measures. So it is a potential danger, which I believe is why it is part of those knowledge, criteria that's covered in that written exam.
So where are we at with this, folks? Are we of a mind now of actually, as opposed to keeping it the way it is, actually changing the verbiage on real ear measurement and say they have to know that has to be something that has to be done as a part of their training? Or are we going to maintain it the way it is and just knowledge of real ear measurement, but they must know how to run electroacoustic analysis?
Yeah, I think you change on 10, you change knowledge to use. Or use and knowledge, and the same potentially for number 7 if you feel like that needs to be made more clear.
I think that's pretty clear as it sits.
So I would agree with what Amy's saying there, that it should be used.
Or just take out knowledge of and put verification techniques for hearing aid fitting, including real ear measurements. Dr. Tulio, Karen, you guys in agreement with that?
Yeah, that's fine.
So we're clarifying the recommendation is not use of, but verification techniques for hearing aid fitting, including real ear measurements. So just the same way as word 10 as the same way as 7.
Right.
Thank you.
Anything else on that page? Have we beat it? Have we beat everyone into submission?
Let's see. Creation of ear mold impressions. Yeah.
I also have a question on the next page that's also a part of 118.
Yeah, we can, let's start, if we could start wrapping up 118, we could, hear
Yep.
from you, and then if we want public comment.
Todd, did you say you have something on?
Yeah.
118
So
also?
under G, where it says supervisors shall be responsible for providing training until whichever of the following first occurs, obtains a permanent license or given written notification of the board they're terminating supervision. What about when the person's time is up? They have 18 months that they're allowed to have a training license, right?
You are correct. They can be
Should
on
we
their-
add that, or is that just assume they're going to terminate the supervision at the end of the 18 months?
I think we should add it.
I think you should.
Okay.
We'll wordsmith some plain language for the vote.
Okay. Okay, that's all I have for that.
If there aren't any more questions to 118, we can move to 119. Unless you, Mr. Borges, if you would like to have public comment on 118.
Why don't we, since we talked a lot about that? Let's open it up for public comment.
We are now accepting public comment on 118. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to return to the agenda? Mr. Chair? Mr. Chair, I believe you're still on mute if you're trying
Sorry
to
about
speak.
that. Shall we go to 119?
Absolutely.
Already? So what were the changes for 1399.119?
Oh, sorry, we were trying to identify if we still have quorum.
I just want to announce that Karen Chang had to step away,
Oh, okay.
but we still have a quorum.
Okay. Phew. We're right near the end. We don't want to lose that now.
Board changes to 119. The board amended to specify different levels of supervision and require higher level of supervision during the first 90 days. We, as board staff, made the requirements applicable to both temporary license types who need to be supervised and remove the definition of supervisions as it exists in the definition section in 1399.102. Again, we included in attachment B the original language that the board adopted in case you want to see how it compares to the highlighted version. And yeah, and then I have a couple discussion questions.
Okay.
I guess I'm looking at item C. I'm not sure if independently, so in item C, we defined the term manage in statute. I'm not sure if we should also include independently operate. I don't know if that needs to be defined. That could be a question to our legal, since the board is taking that opportunity to define manage.
Can you go back to A and B? Is there any other supervisory designation besides direct and immediate?
For that one, so that is one of the questions we're going to look at because as the text reads, to my understanding, it's only direct and immediate supervision. Though in listening to the last meeting, it looks like there was discussion about indirect. And so kind of revisiting to see if that's still something the board wants to consider, or if we aren't allowed to do that according to statute. So yeah, that is a discussion question to talk about a little more.
And so therefore, where does manage show up? Does it show up?
So manage shows up in the actual statute in Business and Professions Code section 2538.30A. Let me pull that up and read to you what it says in its entirety.
I think it's good to define it, but I think you need, there should be slightly different wording. Because it's not for the purposes of the code, it's for the purposes of this section. The term manage as used in the code means. You see what I mean? You're trying to dictate what it means in the statute, and what you need to say is the board is interpreting what's in the statute to mean this.
So in statutes, it says a temporary or trainee licensee shall not be the sole proprietor of, manage, or independently operate a business which engages in the fitting or sale of hearing aids.
If you just change, you strike out for purposes of and put pursuant to section 2538.30A of the code, manage, you're fine. That's better language.
And is the question for 6A, are we happy with the description of direct supervision and immediate supervision?
I assume we borrowed those from other language that already defines those. Is that right?
Yes, I believe so. Like it's a borrow from like SLIPA and RPE. I think it might be a little different, like on site and in proximity to, and available at all times, to provide observation. So there's some language specifically to like what's happens at the hearing aid dispensing. But yes, for the most part, it's the same. Like direct supervision is in person on site. Immediate supervision is physically present and immediately in the room with the person.
I mean, I'm fine with the definitions. I think that's exactly what we want it to be.
So A and B, doesn't seem like there aren't any more questions, and it looks like the legal provided us a bit of clarity for it. And let's see, are there any questions about any like D, E, and F? That's where the we describe some tasks for immediate supervisions and then like the first 90 day and what happens after 90 days.
So we're eliminating the whole 20% of the time, all that kind of stuff. We're kind of simplifying it into the way it's listed now.
Yes.
Okay.
Is there a form, is there a way for the supervisor to countersign? Or is it just, just written in there somewhere?
I thought that was written in there somewhere.
That I believe is the current language.
And if you look at a delivery receipt now, there's only a place for one signature. I'm just curious how they do it or would do it.
Oh, like in the practice, the business practice, like when you guys receive forms.
Yeah.
That would have to be the producer of the form.
So do they have to have a separate line for both signatures? Can they sign on the same line?
We actually, in our documents, we have a separate line for the supervisor, if there is one, on both the purchase agreement and the delivery receipt. Yeah. Are we good on that? I have a question because I have a question about H.
So this idea on F, just for a second, when the supervisor determines competency. Is it saying you do have to do 90, but if it's 80 and the supervisor feels they've got it, they can dispense within 90 days?
Well, it says a
No.
minimum.
It does, but the language is a little funny.
So the language, this was a discussion at that last board meeting. So the board was discussing how they wanted it to be at least minimum 90 days, but give supervisors the flexibility to be more than 90 days.
Yeah, I would agree with Marcia. I think the way it's written, because or is in there, it almost makes it seem like, even though acknowledging it says after a minimum of 90 calendar days, but then it says or until the supervisor determines. Is there a way we can clean that up to make sure it's understood that that has to be the 90 days, and then after that, it's up to the discretion of the supervisor?
You could say or longer until the supervisor determines.
Right. Some sort of legalese, so it doesn't look like an either or statement, one or the other.
Michael kind of suggested whichever comes later, we can add that at the end of after competency.
I think that's clearer.
So it would say after a minimum of 90 calendar days or until the supervisor determines competency, comma, whichever one comes later.
Yes, something like that.
Yeah.
I think the term would be occurs later.
Yeah, we could do that. Are there any questions with D, E, or F?
I don't have an E or F question, but could I shoot you back up to the first paragraph before you start the A, B, C, whatever? You have a superfluous conjunction. You have and in there before for the duration. And you just need to take that out. It's not needed and it makes it less clear. Supervision shall be provided by the supervising dispenser identified according to section 1399.114B for the duration of the temporary license.
Thank you, noted. Yeah, I think for this one, so that first paragraph, the first two sentences originally was like redundant in some parts, so I tried to combine it, and so that was my attempt, so.
I think you've done a great job on these.
I think so
she
too.
had too.
Yeah.
Somebody wanted to go to H. I'm sorry to move you back up, and I don't think you were finished at the end.
Yeah, we can jump to H. My question there was, should we define physically present?
Where was that for?
For H, it says if a trainee applicant or trainee license holder fails the license examination, the supervising dispenser is required to provide to be physically present, and I'm recommending provide immediate supervision.
Right. I like the change. Yeah. Actually, my question is when it says fails the license exam, should we not specify practical or written, since there are two exams?
Good point.
Oh yeah, that was another question actually. Yeah, this on the third page of the memo, it says, yes, if that's something if that's something that the committee wants to do, we can do that as well.
Well, it's also at the very beginning, it's the same thing at 1399.114, where it says the temporary license holder who fails the license examination must provide the board with the following supervision information. So I think we need to also then include that and change that there as well.
That change is noted as well.
So are you changing it to be fails any portion of the license examination or fails the physical?
Written,
So-
do we say written or practical
I think it's
examination?
probably written and or practical, because you can fail the written. And then once you pass the written, you can fail the practical. I guess if that makes sense.
Yeah, what are the wishes of the committee? What are the recommendation? Todd, is this a good time for us to take a
Oh.
quick break?
Okay, sorry about that. I completely lost audio there. And now you're yelling at me because I turned it up too loud. I was going to ask if everyone wanted to take a quick 10-minute break or if they wanted to power through the next section.
Oh,
We're done with 119.
I think we still need clarification on if it's both examinations or one or the other.
Oh, I'm sorry. Paul wanted a break, so I thought we were done, and I seem to have been muted there for a couple minutes, so I didn't hear the last little bit.
Well,
So
my
we're-
understanding, if you're saying you have to pass the first one before you can even take the second one, if you said fails the written or practical license exam, that takes care of the issue.
Yeah, I would agree with that. I
Yeah,
think
that's what I
fails
was looking
either
for.
is really what we're after. Or at least that
Yep.
would be my input.
Yep.
And I stuck that at 114 and then here at 119 at H.
And then we do.
Could we take a quick bio break?
Let's finish this page if we could.
Oh, sorry.
And we have a whole nother issue.
What's the other
Yeah,
issue?
our last question is about, are there any parts in this article that needs a record keeping requirement imposed for the purpose of verification? And it's up to the committee if we want to take it now or take a quick break to discuss it.
Does anyone have any thoughts on that? I mean, does anyone have something they want to discuss in particular concerning that?
We can also bring up, since we are bringing back the language, we can also bring up this question again with a cleaner version to the supervision requirement.
So we haven't moved on to advertising yet, right?
Yep, that's the next section.
Yeah. So can we finish this real quick, or are we near the end, or no? We're not near the end.
Well, I think this is the last question we have, correct, is whether or not there's going to be record keeping.
Okay, Maria, could you say it again, the issue?
So one final question is if the committee / board wants a record keeping requirement in any of the requirements we're creating. So we have, we're requiring like first 90 days of supervisions. There's no clarity on how that's going to get tracked or monitored, if that's, such as well as the training, like we have all these, skills and knowledge we're requiring, but there's also no way to verify or, note, like, how do we know that they completed that?
And currently, we don't know with the existing system.
Yeah.
Right.
Do we monitor that for other, like SLIPAs or?
For SLIPA, we have, since we are also doing the first 90-day requirement, we had the requirement as record keeping as part of the personnel file.
And that's something the board looks at? Or they just ask them to keep track?
Just that you would have to keep it and the board could request it if needed.
And it's a new requirement.
Yeah.
Would
it
you
would
say,
be a
Paul?
new requirement.
So you guys you haven't created any forms or anything that has to be filled out.
No, just something that would have to be tracked and put in their personnel file, this was completed and whatever. And if the board ever wanted to request it, we could always request it.
And it could be something as simple as a statement on letterhead saying they did 90 days or.
Exactly.
So I think that's okay to require.
Yeah, I think we should mirror that.
Yeah, I agree.
There with the slippers. Okay. It sounds like we need a bio break. Why don't we do that bio break and then come back for public comment on this agenda item? That sound good, Todd?
Okay, everyone wants a bio break. Let's take a quick 10-minute break. Are we back?
I'm back.
I'm back to you.
This is Karen. I'm back.
Amy's here.
Staff all there?
Yes, we're good.
I'm here.
Okay, great. Well, let's see what we can do with this next section. Let's go ahead and start on it. It seems relatively cut and dry, but
Just one thing, Todd,
mhm.
just to interrupt, we have to take public comment on the last.
Oh, right, correct.
Just wrap it up.
Yep. Sure thing. Well, let's go ahead and do that real quick.
We are now taking public comment on the matter. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, would you like to return to the agenda?
Please.
Agenda item 4 is discussion and possible action to amend regulations regarding hearing aid dispenser advertising requirements as stated in Title 16 CCR Section 1399.127. So due to inquiries and complaints received regarding the lack of clarity with the regulations, at its June 2013 meeting, the board approved proposed regulatory changes. At its May 2016 meeting, the board amended the board revised the proposed regulatory language and yeah, so since 2013, the board's been looking at these regulations to clean up, and it wasn't until 2016, 2017 that the board delegated it to 2 board members to make further revisions. The board approved the language in August 2017, but due to limited staff resources, we just haven't been able to get it moving forward. And so now I'm moving this one forward and giving you the hearing aid committee the opportunity to review it before we present it to the board. And so the summary of changes is what the board has approved in August 2017. So just various amendments to A and B to increase clarity and remove that table, paragraphs with tables in there. Sections were added, I believe, to kind of specify what those tables meant in clearer terms, as well as the revision to the last item that was already there. I don't have discussion questions because I'm not too familiar with the issues and to this area of the regulations. So we can open up to board discussion and public comment to kind of see what else needs to be addressed in this regulation.
So if I may, you're essentially eliminating that whole section where it gives the examples of the right way and the wrong way to do it. And filling it in with just an explanation of this is what you need to do.
Yes, I believe that was the issues was that the tables and information caused a lot of confusion of how to advertise. So kind of revising the words so that's more the language that's more clear to the public and licensee.
Okay. So in section B, where it says an advertisement for fitting and selling hearing aids and or other authorized services is false, etc., violates any provision of Article 8. That's a standalone statement. Basically, you just go to go to that section to see what
Yeah.
those things are.
So my understanding, as I'm working to draft on the ISOR for the regulatory package, Section A is to make the provisions applicable to dispensing audiologists. Since they are going to be required to meet these advertisement requirements. And currently, as the language is saying, I think it kind of limits to just the one license type. And in B, it's including that because my understanding is the advertisement requirements are in section 651 of the Business Profession Code. We also want to note that we have advertisement requirements in the hearing aid dispenser sections. And so that would be any violations to those requirements are considered a violation to section 651.
Gotcha.
And so what we have in section 2538.10, which is the start of the hearing aid dispensers, some advertisement includes like, I think noted, maybe the hearing aid, lock hearing aid kind of things. I'm not quite too familiar what kind of advertising all this consists of, but yeah, since you are in the practice, if there was any concerns or issues with the way the language reads.
Well, let's just take it. We can go briefly down. Does anyone have any concerns or questions about section A or B under 1399.127? Okay. Hearing none. Section C or D.
Yeah, for section C and D, it looks like for section C, it's regarding the name and the license number, making sure that's clear and available, pursuing to Business and Professions Code. And then for D, it's regarding to like education, job title, what can and cannot be included.
Does anyone have any questions or concerns? Section D, items 1 through 6. Anyone concerned about the verbiage or the clarity?
I think D1, an educational degree that was not earned and does not specify the exact degree and field in which the degree was earned. So if they said, I have a BA in biology, that would be okay, so long as they say what it is.
Yeah, my question when it says not earned, is that like an honorarium? An honorary degree? I got a master's in letters from, someplace because I gave them a lot of money.
Yeah, that may be the situation, honorary degree.
So if they had a degree in biology, they could say, master's degree biology, and that would be okay in the advertising.
Can't imagine why they would do it, but I would assume that under those current rules, that would be acceptable.
Yeah, I agree. I don't know why they do it either.
But they can if they want.
I mean, it's true.
And I think going back to the first question, I think that an educational degree that was not earned, I think this is in the context of false advertising or fraudulent advertising. So saying that you have a degree that you don't have, or implying that you do.
Oh, gotcha. Okay.
So audiologists cannot be calling themselves doctor without saying AUD, having that designation.
And that's the way it is now, is it not?
I hope so.
I always thought that was requirement.
Is there any situations where a hearing aid dispenser can like complete a program but not be licensed, or is that?
Yes, you could, but why you wouldn't apply for your audiology license at that point, I don't know.
Well, that worked because I don't know if you all remember this, but many years ago there was a gentleman in the Bay Area who had his doctorate in biochemistry or something, and he would always call himself Doctor whatever his name was, and people went just nuts over that because he was calling himself a doctor when he didn't have anything to do with audiology, and he was sued multiple times and he won every time because he actually had a doctorate.
Yeah.
So yeah, this is, I like this clarification.
But then people know if you have a doctorate in some random other thing, at least it's something random.
Right. Okay. So then on the next page, section 4, 5, and 6.
Wait, on 3, can you tell me the term audio prosthologist, is that a designation that's given by HIS or another INS?
That's that hasn't been around for a number of years. They said they were revamping it
So
like
they're not used anymore?
six years ago, and it hasn't come out since then. But yeah, that was done through the national IHS.
So people aren't using it anymore. That's what you're
I'm
saying.
sure there are probably some people are still using it because they got it a number of years ago. So I'm sure there are still people that do it, but they might say whatever the acronym designation is for it, or they might. I've even seen some people where they'll say audio. I always call it audio proctologist, but you know, whatever it is, and they wouldn't specify necessarily. So according to these rules, they would have to say that it came from IHS, that it was awarded by them.
Not clearly identified by full job title. Oh, so they could just say audio prosthologist, IHS. Okay.
Any other questions on that, on those first 3 sections? Okay, let's turn and look at 4, 5, and 6. I like the addition of specifying a research or field study, because sometimes you get some pretty dubious advertising.
Mhm.
I'm not sure where 6 comes into play. I don't know how you do that, but so I don't really know what that's referencing. A preset appointment.
I've had lots of patients call that are confused. They thought that they're coming to me for an appointment, but really they'd received an advertisement for some other place down the street that said, hey, you have an appointment with us at 11 o'clock on Friday, October 5th.
Okay, gotcha, gotcha. I've not seen that kind of advertising before. Okay.
I have.
Hmm.
Been a while though. I don't see it much anymore.
Yeah. Okay. Any other questions about those 3? Any concern about the rebate coupons? I have a question of clarification for G. An advertisement of price shall not be used to entice the consumer into a more costly transaction than the advertised item or service. This sounds to me like those ads where it says you can get this hearing aid for, you know, $9.99, and then when they walk in, they upsell them into the $6,000 set of hearing aids because that one's not quote unquote right for them. Is that what we're targeting here?
With car sales, they'll advertise a few at $29.99, almost $30,000, but most of them cost higher than that, and they only
Right.
have 4 available that are at that price, and everything else is more expensive.
But we don't normally have, I have one hearing aid for, I mean, I guess where it comes into play for me is in the very fine print where it says just good for mild to moderate hearing losses. Is that what this is targeting? I'm just curious where this came from.
I believe that's what it is, Todd. I think it's a bait and switch type of advertisement.
Okay. So if someone comes to you and complains, I went in for the $599 hearing aid and they sold me the $4,000 hearing aid, then they're potentially in violation of this particular section.
Yes. Well,
Okay.
we've had cases in which they were in violation of the Practice Act. I don't know specifically if that would be in violation of this section, but I think that's what this is intended to prevent.
Okay.
So I think it would be, I think there's a lot involved with every specific case that deals with that.
Right. Okay.
Todd, is the concern that about the clarification of for mild or moderate hearing loss, that you're going to get a complaint against you because you advertised for the mild to moderate hearing loss hearing aid, but the person that came in wanting the $599 hearing aid, their hearing loss is so severe that they don't, it's not going to be useful for them. So you had to sell them the $1,000 or $3,500 one. I'm just trying to understand the concern. Maybe I missed.
Are there any other questions about E, F, or G?
I have a question about G. It says the last sentence in the upper paragraph, an advertisement that offers a price discount shall, number 1, list the dollar amount of the non-discounted fee for the specific hearing aid or provide consumers with a method to ascertain the actual price. So one of the practices of the 3 PAs is to exaggerate the retail price and therefore make the discount look bigger. So I don't know how you control that so that original retail is true.
Right. Because they'll say it's $10,000, but
See, we're giving it to you for 6. What a deal.
yeah.
So and there's I don't know what, we can't do anything about 3 PAs, but some of them have been just ridiculous in how much they're saying it really truly retails for $8,000 and we're giving it to you for $500. What a deal is that?
But I guess there's really no way to address that though in
Well, I'm sorry, isn't it pertaining more to what the, whatever location that is? So, hearing aid wide practice, what they would normally sell that hearing aid for, and just being able to say, hey, our normal price is $8,000, but if you come in by such and such date, you're getting it for 6. As long as they, I guess then it would be incumbent upon them to show that they do actually sell that same unit for $8,000 at other times.
Yeah, you just don't know if that's true. But you're right, there's no way to tell.
Yeah.
Is the actual price the retail price?
Sorry?
Yeah. Right. Well,
So-
yeah,
so
is the
that
actual
would be-
price mean retail, like MSRP, for instance, which we
I
all
would
know
say
is,
if they ever sell it for the $15,000 MSRP and they do indeed sell hearing aids for MSRP at 15 grand, then that's what that practice does. And then that's not a false statement that they're offering it for $2,000 less or whatever. I mean, so I think, we can't necessarily say it can't be this inflated MSRP price because maybe there are places that do sell it for that MSRP price at other times, right?
Yeah, you
but I
can
guess,
clarify either way.
I guess this is just a way to try to hold the business's feet to the fire to be able to say, okay, you're giving me 2,000 off, but 2,000 off what?
Right.
So it just gives a more specific, oh, I'm getting 2,000, am I getting 2,000 off 4,000 or am I getting 2,000 off 8,000? So, I just see it as a way for more transparency, I guess would be the point.
Yeah, I agree. I mean, I don't think there's
Yeah,
necessarily a better way to do that.
right. Any other issues with G? Okay, hearing none. The last section, H. I have a question about 2, but I want to get someone else's comment on whether they have an issue with 1 or 2.
What's that first? Any national advertisement run in California shall comply with California laws and regulations. 1, exempt from said advertising is paragraph C of this section. What is that saying? Exempt from?
C is the one, I think, where you have to list the business address and the phone number, yes? Since it's a national ad, they have no way of listing
they
all
don't
the
have to do
addresses and
that?
phone numbers.
Okay.
My concern is that I'm going to be subject to disciplinary action if my national company, decides to put out some, boneheaded advertisement, and now I'm held responsible for it.
That's my concern too.
Could it not be adjusted somehow to say, if that licensee is noted in the ad, like their, name at this site, at this, come to our Lodi office and, see Todd and yada, yada, yada. I mean,
Yeah.
if it's a national ad that's not specific to a location versus, the specific location of the dispenser.
I do think, I agree that there's a delineation there, because if there's just a corporate advertisement out there and you happen to be employed by a large company, that's one thing. But if they're specifically saying that at your location, they're offering this and it's a fraudulent practice or some type of false advertising, then I do think that you could be held accountable as a licensee.
Well, and that's what I'm saying, right? So if they do an ad that doesn't specify the actual price of the hearing aid, if they violate any of these particular caveats here, then I'm the one who potentially gets fined or gets put on probation, and potentially lose my license because of an advertisement that they did.
I tend to agree with Todd on this one because I'm thinking of a big company. If say Todd sells XYZ hearing aids, this company XYZ knows that Todd sells them. They might not even ask for permission from Todd. They'll just say, hey, come to this office. This is where we sell it. This is what, this is how much it's going for. And then
Yeah.
Todd gets in trouble.
Yeah, because they have marketing departments that create these things and spew them out.
Yeah,
and we have no visibility to it prior to it hitting the streets.
However, you can correct it. I mean, you can say, you can call them up and say, hey guys, that's actually against my state regs. You can't put that in there. And then surely if you were contacted by the licensing board to question it, you can say, I do understand, and this is what I did, you know, and right. So if we don't hold the national advertising to the state standard, then it's really unfair to places that aren't national, because then the national chains can do whatever they want, and those that aren't part of a national franchise cannot, and it makes it very unfair in terms of advertising.
Well, I think that we should hold them to the same standard. I just, don't want to have to pay the fine.
Can we like do something to the national chain? If it's a national chain that's doing this ad, then shouldn't the national chain be responsible?
I think there's a way to address advertising issues that take place in the state of California. I mean, this is obviously a complicated issue, but I also think that the licensee is responsible for advertising that is false or in violation of the law. If that licensee is associated with it. It's not enough to just say, well, I had nothing to do with it because I don't have control over this, if they're partaking of it or benefiting from it.
I'm curious. So the reading says that the subject to discipline or enforcement action is for sales resulting from a national advertisement that violates this section. Is there a clause that unless the licensed hearing aid dispenser notifies the consumer of 1, 2, and 3? So if they come in and say, oh, I saw your sale ad on whatever, and you as the dispenser say, oh, but I want to make sure you know 1, 2, and 3, this was the actual price, this is the sale, and that it's only limited to this or whatever. As long as you inform the consumer, does that help take away that I need to enforce it against you? Because then you've told the consumer that information prior to the sale. So you're not making the sale without informing them. Does that make it clearer? Like, it's your job. You can't make your company do everything right, but you can do everything right as the hearing aid dispenser and tell them blah, 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 1, 2, and 3. And if I do that and I inform them of everything that the advertisement should have told them, and then that consumer still proceeds with the sale, are we okay?
It sounds like you're saying I'm telling the consumer I'm in violation of the law, but I'm letting you know that I'm in violation of the law. So therefore I'm absolved from violating the law.
I'm just thinking if my company has violated the law
Right.
and the dimwits in marketing don't follow my regulations.
I just don't think licensing works that way. If a licensee is in violation of the law, then they're.
I guess that's what it comes down to, is who is accountable, right? Because I'm not responsible for violating the law. My company's responsible for violating the law.
And Todd's going to have a lot of angry customers if he's not going to sell this, if he can't sell this hearing aid at that price. But he doesn't want to violate the law.
But then again, we're just saying then it doesn't matter. Why do we even have the advertising requirements if it means that if I work for a national company, that my national company can do whatever they want, and I don't have to inform them or notify them that, hey, you can't advertise that way in my state because it's against the rules, and trying to keep that in check. I mean, I don't understand how we cannot hold them accountable, the licensee accountable.
Can we hold the national company accountable?
Right. That's my question, along with Karen, is there any way to hold the company itself responsible as opposed to the individual?
Because when they give out these coupons, sometimes I'll see like not applicable in Minnesota, New York, and California. Right? So these companies will know, but we need to keep them accountable to that.
We have had cases where we've seen that. I mean, I had a conversation with someone, and the very next week, I saw the advertisement on MSNBC, and it exempted our state from that advertisement. So I do think that they're listening, and I do think that they take action at times. But I don't think it's as simple as saying that we're going to exempt licensees from all violations that are involved with national advertisements. I think everything is on a case-by-case basis and has its own fact pattern. So it's really difficult to say that, but I do think that these regulations are based on Business and Professions Code 651 that's already in existence. And I think they're meant to clarify that law for those licensees so that they have an idea of, you know, when they're running, when they're in violation of law.
Well, it makes them be more present. That's for
Right.
sure. I understand that. And I appreciate the explanation. That makes sense to me.
I did have a question. Just I don't want to get too much off track here, but for those members of the committee that have dispensed hearing aids, the way the advertisements were written before, was the old format effective in understanding the laws compared to what we're proposing now? Or were you even aware of them?
You mean the examples that now are all read, struck out with the correct, incorrect? Is that what you're talking about?
Yes.
I liked that a lot myself. I definitely use them in previous locations that I was working to because some of it seems so gray. Having these specific examples, I found personally to be very helpful.
Me too.
So here's my question. Do you think they need to be in a regulation, or they're good educational materials that the board should have as part of its website and educational material?
Good question.
Because having clear requirements in your regulations is kind of the goal, but that doesn't preclude the board from having educational materials and that sort of information and including as part of the candidate handbooks for the written exam and the rest of it. You know, these are some of the information on advertising. This is information on do's and don'ts for these kind of things that are clear displays of what the requirement is, but here's the plain language, what it could look like when you're doing it.
Well, why don't we do this? Because we're getting really right up close to 5 now. If we want to table this and talk about it a little bit more tomorrow morning, we can do that. If everyone's comfortable with the way as it stands for now, and then they have a chance to get it kind of put back together again. And then when it gets presented to us again, we can, discuss it again at that time.
Well, I think we have our board agenda to probably cover tomorrow, and I know we have something scheduled, so we may be tabling it for the next hearing aid dispensers committee meeting, which would be okay because we're going to have other materials to look at, and that would probably give our staff and the regulations council more time to look at these hearing aid dispensing advertising guidelines.
That sounds like a good idea. Does everyone agree?
I agree.
Okay.
Yep.
Okay. Well, let's go ahead and open it for public comment.
We are now open for public comment. If you would like to make a comment, please type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Dial-in users, please dial *3 to raise your hand. It should be noted that besides the panelists, there is no one in the public.
Okay, we wore them down.
Can I ask a question? At both of the items for hearing aid dispensers, the last item is if action desired, call for a roll call vote. And I don't think we made any changes to the second to number 4, but for 3, there were a number of small changes to the language. Does that require a vote or not necessarily?
I don't think it's necessary at this point because we're going to come back with more revisions in language.
Yeah.
Okay.
I think we would need to vote once it's finalized. Is that how it would?
Yes.
Sounds like
Lay
we'll
out.
make additional
Yeah.
revisions and bring both of these agenda items back to you, most likely at the October meeting, where we would hope to do a vote.
Okay.
And then hopefully by that time, the committee's ready to make that recommendation.
Okay.
Great. Well, I guess you can close the public comment since there's no one there to comment.
Not unless board staff wishes to act as a public.
Board staff is not the public.
I think that was Michael. Thank you.
Okay. Well,
You want to adjourn your committee meeting?
I was just going to say, I think we wrapped everything up well, so we'll go ahead and adjourn the committee meeting. Thank you all very much for the discussion. It was very good.
Thank you.
Okay, seeing that it is almost 5 o'clock, and we have a full agenda for tomorrow, we should adjourn the general meeting as well. We meet tomorrow morning at 9 o'clock, and hopefully we'll see everyone there, but this meeting is adjourned.
Thank you all.
Thank
Bye,
you.
everybody.
Bye.
Good
Have a good
job.
one. Thank you.
Bye. See you tomorrow.
Bye.